Thank you guys. Ishan and I just wanted to introduce ourselves. I'm Lauren Shapiro. I'm one of the hand and upper extremity surgeons here.
Morning, everybody. I'm Ishan Swarup. I'm one of the pediatric orthopedic surgeons here.
And we wanted to welcome you guys all to San Francisco. I'm glad we got some good weather for most of you guys who are visiting. We wanted to thank the OREF for co-hosting this with us and helping us organize this. Wanted a special thank you to KJ, William, Bridget, and Mary, who really helped get this program together and running today. Welcome to San Francisco. We have a good program for you.
All right, just a couple of housekeeping things. You know, everybody should have the program in the packet. For those that are presenting, Dr. Shapiro and I will introduce you. You'll come on up, give your talk, and then you can have a seat right here in the front row for the Q&A session. And then for the rest of the audience, there is a scoring sheet in your packet as well, so make sure you kind of fill that out as we go. And then there'll be awards towards the end, and at the very end, we'll try to do a group photo, so if you can stick around, there will be lunch too, which is incentive. So if you can stick around, that would be great, so we can do a group photo of everybody here at our institution. So without further ado, I'd like to call our department chair up to do a welcome. Dr. Ben Ma has been our department chair now for almost 2 years, and he will welcome everybody and give us a little bit of a brief introduction to UCSF and to OREF.
Thank you over there. So I'm Ben Ma, chair of the Department of Orthopedic Surgery at UCSF. So welcome to San Francisco. I know that Dr. Swarup and Shapiro already said it over there, but you know, we are very happy to welcome you all to San Francisco, and we picked the right weather, as Dr. Shapiro mentioned. I do want to thank OREF to allow us to kind of host the meeting. This is important for us. Research is kind of paramount with what we do in orthopedics. I want to share with you all is that OREF actually awarded my first ever grant, Lee. So actually, I was a resident. I got the first, grant as a fourth-year resident, and I'm fortunate to kind of able to advance my career. And I think that make sure that you spend the day. I see a lot of pockets of different applicants, different residents got seen together. This is a time to mingle. This is a time to I want you to really kind of learn more from each other about what each other's doing. Share about the experience as a learner. Share experience about doing research. Share experience about how to each program works, and hopefully bring it back to your program, make your program better. So that's how we learn from each other. And I'm looking forward to all the great talks today. This is exciting. I think that we learn so much from each other. And without further ado, I'm going to turn the podium over to Lee. Grossman. Lee is actually the Chief Executive Officer at OREF. Isaac shared about his vision. But thank you so much for allowing us to be part of this. Thanks, Lee.
Thank you, Dr. Ma. I appreciate you sharing your OREF origin story. It doesn't fail every time I go to some sort of meeting. There's a person that is a department chair, for example, or head of the research department that seems to have always share their OREF origin story, that their start in research started with an OREF grant, and you're going to hear a little bit more about that this morning. Thank you for having the Orthopedic Research and Education Foundation here. I'm going to do a little bit of housekeeping before I give somewhat of an explanation of OREF so that you know who we are and what we do. It's really, indeed, a great pleasure for me to be here at UCSF. Dr. Ma knows how to put the meat in the seats and get a great audience here for this, and we really appreciate this. This is, I believe, our 23rd year of doing these Resident Research Symposia. This is the fourth one that we're doing in 2025. We've already done one at the University of Miami, University of Pittsburgh. Last week we were at the University of Chicago. We're here this week. In a couple weeks we'll be at the Hospital for Special Surgery. And then on November 12th, our national symposium will be held. A couple of the housekeeping things. The presentations are broken up into sections. So the judges will be our moderators as well, and they'll be calling you up individually in your section. When you come up to the laptop, you'll see that that your talk is organized in the section that you're presenting in. So if you're in section 1, go to section 1, you'll click on that, you'll find your presentation, and then just pull it up and put it in presenter mode. I know that's unusual for a boomer such as myself to be explaining that to you, and hopefully I'll be able to do it when I pull up my slides. So we'll see if I'm tech savvy enough to do that. After you finish your presentation, those people that are in that particular section, please sit up here in the front, because after everybody is presented in that section, you'll be called to the front, and the judges will be asking you questions. If there's time, we're going to be also taking questions from the audience. When you are up here in the front answering those questions, there'll be a microphone. We're recording this, so everybody please speak into the microphone, and we'll have a microphone for you to pass back and forth. All of you have received sheets for judging your fellow presenters. At the end of the day, we will be awarding the person that all of you have selected as the best presentation as our Best Presenter Award, and they will be receiving a cash prize. The top 3, there will be cash prizes for the top 3 presenters today, and the top 3 presenters go on to our national competition, which is again on November 12th. That is a virtual symposium, and you'll be presenting there and then judged. And our winner of the national symposia gets an all-expense paid trip to the Academy meeting, which is in March in New Orleans, Louisiana, where a good time is always had by all. After you're done with each session, please, for those that are judging, please hand in your sheets to Carmen, who is the person that was at the registration desk when you got here. Again, I just want to reiterate, we're recording all of this, so if you're speaking, please talk into the mic. With that said, let me see if I can do this and get my presentation up. Oh, see, I did it. Very proud of myself. I'm not that tech savvy. So for all of you in here, you probably have heard about OREF, but a lot of people just don't know who we are and what we do. So I'll be getting into that a little bit later. But first of all, I want to thank Dr. Ma and the University of California, San Francisco Department of Surgery for hosting us today. It's always an honor for us to be here. San Francisco always has been one of my favorite cities, and it's always a great excuse to come here. So I'm always happy to be here. I'll be here next week for DocSF. And I want to thank Dr. Shea, who is our keynote speaker today, as well as our judges who you'll be hearing from throughout the day. We want to thank our industry sponsors. We're very grateful to them, because without them, we wouldn't be able to put these significant programs on. And lastly, we want to thank the Hark family, who has been very, very generous in supporting this as well as other educational programs at OREF, and they too are very much responsible for making this happen. So I'll give a quick rundown of who and what OREF is. We've been around for 70 years. This is our 70th year, and you'll be hearing a lot more about our 70th year and moving into our 75th year as we go forward. We are an independent organization. We're not like the other professional associations. We are a 501c3 charitable foundation. So we are very different. We don't have members. We rely entirely on money that is donated to us to fund the research. That independence is a superpower of ours. We do not have to be responsive to special interests. We can go out and therefore fund the highest priorities and the best research that is presented. And that has been one of the very, very important and key aspects of our success over the years. Last year, we awarded over $1 million in grants, and at any one time, we have an active portfolio of grants that we're managing of approximately $8 million and 100 grants that we're managing at any one time. One of the most important aspects of our mission is funding and feeding the pipeline of new investigators, supporting those individuals that want to make research a part of their clinical practice and part of their careers. And I say that it's something I'm very, very proud of that we do, because we're essentially almost the only game in town that does that. And I'm also kind of sad because of the amount of money that we have to support these promising clinicians who want to have research as part of their career, that the funding is so limited that there's many people that are worthy that we just don't have the money to give to them. We see ourselves as a unifying force in orthopedics. We collaborate with over 60 other MSK organizations. And as you can see from the pie chart, on any particular year, we're funding almost every aspect and every subspecialty of MSK research. And we're very, very proud of that. The middle graph shows the amount of money over the last 5 years that we have spent supporting resident research. It's over $900,000. And we also raise money for other organizations, these partners that we have, these 60 organizations that we partner with. And that's been over $4 million that we've raised to support research and education efforts for other organizations over the last 5 years. In total, over the last 5 years, we've raised, and our mission has supported in research and other organizations about $20 million. These are the departments around the country that support us. As I said before, we're entirely funded independently. About 70% of our funding comes from orthopedic surgeons who find value in what we do and the importance of the research that we fund. And I'm very, very proud and happy to say that UCSF has been a supporter of us for many, many years, and we can't thank you enough for supporting us in the way that you do. People ask us, well, you know, do you have any documentation showing how successful you are? We have a lot of documentation on our impact. This is a graph of a study that Nick Bernthal at UCLA and his group has done. He's actually updated this recently. It's been published in JBJS, showing the impact that our grants have in terms of going on to get greater funding. If you get an OREF grant, according to their research, you have about a 20% chance of going on to get greater funding from the federal government. Our career development grants, which are our largest signature grants, about 50% of those go on to receive major funding from the federal government to the tune of about 500% over what we've initially funded. We develop future clinicians. For those people that receive resident grants from us, about 64% of them go on to academic careers. We've also, there's other studies that have shown that by us fostering those people that are even presenting here, that a good majority of them go on to pursue academic careers. So for those of you presenting and receiving awards today, that might be part of your future. Our impact, we've looked at our 4,700 grants that we have funded over the years, and Dr. Skokol, Greenwald, and Heckman a few years ago, with the help of Dr. Cummins, who is the person that's really responsible for this program today. They looked at our 4,700 grants and determined the top 250 grants that changed clinical practice. And this is just a very, very small sampling of the type of grants that we've funded that have changed clinical practice. And again, you can see the breadth of the topics and specialty areas that we fund. I want to switch gears a little bit because this year, this has become a priority effort for OREF, and that's looking at the great burden of disease that MSK has, and MSK burden of disease dominates healthcare. It's approximately $1 trillion a year in MSK issues that are spent in the United States every year to address patients that come in with various MSK-related problems. And in spite of the fact that MSK dominates healthcare, the amount of research funding is among the lowest of any medical specialty. There's a great disparity between the burden of disease and the amount of research funding. And that has been tremendously impacted negatively since January, where much of the funding that was already allocated to us has been on the chopping block, and we've lost a significant amount of that. And it doesn't bode well for the future. So what OREF has been doing is meeting with many of the other organizations and suggesting and trying to unify the MSK community to not only advocate stronger for MSK research funding, but also to come together to fund the type of research that we probably aren't going to be able to get through our federal funding agencies. And ORF has been able to show that we can do this type of funding, these major, significant, impactful, multi-centered, retrospective grants in a manner that's much less expensive than what the federal government is doing. But by pulling our resources together, working together, that we can put these types of research efforts together, and they're so needed in MSK. We have been saying at OREF that our national healthcare systems will not be improved unless and until MSK research is made a priority. And we feel very, very strongly about that. We are organizing our research efforts primarily in these three categories just to make it this breadth of MSK much more manageable, looking at pain, emerging technologies, and biologics as priorities. And just want to finish by saying that nobody does what OREF does in terms of improving clinical practice, feeding the pipeline of early investigators, driving innovation in MSK, and funding all aspects of MSK research. Your support to us is now more important than ever. And we hope that you will, over the years, be very supportive to our mission and what we do here. For the residents, we do have a program that we have with Medacta, and they're matching any gifts that come to us from residents. So we're accepting gifts from residents as low as $25, and Medacta will match that. So that type of gift gets doubled to support our efforts, and also shows the willingness of those orthopedic surgeons to support MSK research. So I want to thank you for being here. Thank you for your support of OREF. Thank you for driving clinical MSK research forward, and good luck today. I hope that all of you enjoy the presentations, and for those of you who are presenting, very much good luck, and thank you for your participation. Thank you.
Thank you, Lee. We'll go ahead and get started with session 1. This is the sports medicine presentation section. Please hold your questions for the end. We'll do a Q&A session, and the judges will have some questions prepared as well. So we'll start off with Grant Schroeder from our neighbor down south at Stanford, talking about shorter relative patellar defect length after BTB ACL reconstruction is associated with better post-op patient-reported outcomes at 1 year follow-up. Thanks, Grant.
Alrighty, thank you so much for having me. Thank you to OREF and UCSF for hosting. Yes, I'm a PGY4 at Stanford, excited to share a little bit about this research project. Going to be talking about BTB ACL reconstruction, specifically the donor site morbidity. We're looking at the patellar defect site and the dimensions of those. We all like BTB for its low rates of failure, bone-on-bone healing, but we know that anterior knee pain is a drawback to ACL reconstruction with BTB, so we wanted to look into what is a potential mechanism of this. So we looked at the dimensions of the patellar defect site. You can see some examples over here at a short MRI 6 weeks after surgery, so you can see a large defect at the site of the bony harvest compared to 1 year. And we noticed that some of those had remodeled pretty well versus others hadn't. Some were initially very large, others were smaller. And so we asked the question, is the initial size of the patellar bone defect or the bony remodeling in the first year post-op associated with patient outcomes? With the hypothesis that due to donor site morbidity, that larger bone defects at the time of surgery and larger residual defects at 1 year would be associated with worse outcomes. So this was a cohort study. We had 23 patients who had filled out KOOS scores at 6 weeks and 1 year, and also had an MRI at those time points. We went and made these measurements you see here, measuring the defect dimensions as well as the dimensions of the overall patella so that we could make relative measurements. For example, if you look on panel C, that's the relative dividing E over F. There's the relative defect length, the length of the defect divided by the pole-to-pole patellar length. And then we compared these with patient-reported outcomes. So just kind of the basic dimensional changes of what happened. We noticed that between 6 weeks and 1 year, the width and depth of the patellar defect site decreased, but the length did not significantly change, so it sort of filled in, but you could still see the residual length at a year's time pretty well. This is the meat of the results here, a shorter relative defect length. So again, that's that ratio of the length of the bone block divided by the overall length of the patella. At 6 weeks, so shortly after surgery, was associated with better KOOS scores at 1 year post-operatively in all the subscales except for symptoms, which everyone essentially did pretty well in that category. So you see over here, these are the 4 subscales. As you go further on the right of the graph, you can see there is decreasing KOOS scores associated with a longer relative defect, and that's true for these 4, and these were all significant associations. The only other significant finding was that a larger absolute defect depth at 1 year was also associated with worse KOOS scores in the category of pain. Looking at people who achieved PASS. So PASS is a threshold in the literature for each subscale within KOOS. Essentially, are they at this threshold for being satisfied with their knee? If you looked at people who passed versus who didn't, they had a shorter defect for those who passed. It was 12% shorter for the pain category and 14% shorter for the sports and rec. If you look at the examples over here in the images, you can see that the defect length in both of these knees is about 23 millimeters, but the patient on the bottom has a much shorter patella length, only 37 millimeters versus 44 millimeters on the top. So you can see proportionally this is a much longer defect, and so I would have to guess that the patient on the top with a shorter relative defect probably did better. We performed an ROC analysis. From this analysis at the top, you can see that there were different cut points that best kind of distinguish those who passed versus those who didn't. What the ROC analysis determined was essentially a good way of saying if you were above this level, you had a very low likelihood of passing. We decided to change that threshold because we want to know below this level, when can we be pretty confident that you're going to pass and be satisfied. And so actually a good defect cutoff length was 0.5, so half of the length of the pole-to-pole patellar length was a great way to decipher that if you're below this, you can be fairly confident that you're going to achieve pass. So you can see in these categories here, 8 out of 8, 100% achieve that if you were below 0.5 versus only 36% in the categories of pain. And you can see that essentially at minimum 75% in ADLs, again 100% if you're below this for sports and rec, and then 88% versus much lower percentages if you're above this level. Again, this is breaking it down based on if the relative defect length is less than 0.5 versus greater than 0.5, and in all the categories, the average KOOS score was higher with sports and rec and quality of life achieving statistical significance. So in conclusion, the key points from this study were that a shorter relative defect length at 6 weeks post-op was associated with better KOOS scores at 1 year post-operatively. So I think this is something to think about, thinking about the relative size of the patient versus just taking a standard length, and this perhaps a 50% of the length of the pole-to-pole Patellar length could be a clinically useful target. Obviously, more research would be needed there. We did look at the specific question within the KOOS questionnaire of do you have difficulty with kneeling, and that also was significant. So again, I think this points to some of the anterior knee pain being a contributor here. And then we saw that the larger absolute defect depth at 1 year also is associated with worse KOOS pain in that category. So I think this lends some support to filling the bony defect and trying to decrease the depth as much as possible, which a lot of people do with residual bone graft. Limitations, this is a small sample size, and we cannot determine the causality of these associations, but I think it opens the door for a lot of future directions, which I'm excited about. I think it'd be great to look at a larger sample. Obviously, the question is, how short can you go? What is the minimum bone block length for fixation? There's some studies suggesting that in cadavers, as well as a porcine model, that maybe 10 millimeters is actually not associated with any decrease in strength compared to a 20 millimeter block. And then what's the mechanism of pain? We're not really sure, but there are studies as well on the stress redistribution from taking these bone blocks away from the patella on the tension band side of the patella. And so I think that strain redistribution and remodeling could be one potential explanation for this residual pain. I'd like to thank my co-authors and the surgeons who helped recruit patients to fill out these questionnaires and get their post-operative MRIs. And happy to take questions at the end. Thank you.
Thanks, Grant. Next up is Dr. Smith from University of California, San Diego, talking about combined root and body lateral meniscus tears in the adolescent population, an under-recognized and under-reported tear pattern. Thank you.
All right, thank you so much. I'm Karch Smith. I'm one of the PGY3s at UC San Diego, and this was a novel meniscal tear pattern that I found with Dr. Pennock, and special thanks to him for providing cases and the vision behind this study. No funding was received for this project and no relevant disclosures. So previously labeled as the silent epidemic, meniscal root tears have historically suffered from inadequate recognition and underdiagnosis. In recent years, however, there's growing interest in meniscal root tears, and this is driven largely by their inconsistent clinical presentation, their diagnostic difficulty, and then of course their association with ACL tears. And we know from the literature that lateral meniscus root tears or posterior lateral meniscus root tears have an incidence of 7 to 14% among patients undergoing ACL surgery. And often the trauma incurred from that ACL injury or the energy incurred can induce complexity to that lateral meniscus such that we're seeing anecdotally combined lesions. So you have that root tear of the lateral meniscus, and often that's combined with a radial tear of that body, or a combined root and body lesion, or in other words, a crab lesion. And if you can convince yourself it kind of looks like a stone crab claw. These stone crabs are native to Florida. Unfortunately, they're not native to San Diego, which would have added some zest to our paper. This is underreported in the literature. There's no studies talking about this injury in the adolescent population or this pattern. There's one study in the Journal of Arthroscopy in 2016 on the adult side that discussed it. So given that little is known about this injury pattern, and given that we know from this study at Mayo that 66% of the time an isolated lateral meniscus root tear is missed on preoperative imaging, we hypothesize that it's likely that these crab tears are also underdiagnosed and possibly undertreated. Here's another image of what this tear looks like. So you have that posterior root tear that corresponds to that indentation you're seeing along the crab claw, and then that central indentation corresponding with that radial body tear. So the purpose of our study was to describe the incidence of crab tears in adolescents undergoing ACL reconstruction, retrospectively analyze those patients with regard to their demographics, imaging findings, and then arthroscopic findings, and then determine the rate at which this injury pattern was missed by the radiologists on preoperative imaging. Here's a flow chart of our inclusion and exclusion criteria. So we had patients undergoing primary ACL reconstruction, and we excluded those patients there, and of 8 left us with 227 patients. From that, we had 23 crab tears, and then we made a randomized control group that was 2 to 1 selected. So what did we find? Well, we found in adolescents undergoing primary ACL reconstruction, the rate at which a crab tear is found is 10% of the time. And I'm going to direct your attention to that side of the screen because, interestingly, it was actually rarer to see an isolated posterior lateral meniscus root tear in the setting of an ACL injury, and it was more common that you actually saw a combined lesion. What else did we find about these crab tears? Well, they associate with higher BMI, higher weight. You can see in that row there discussing meniscal extrusion that there's a trend towards them being associated with higher rates of meniscal extrusion, though that was not statistically significant. They have high rates of non-classic bone bruising. We know that classic bone bruising in the setting of an ACL injury is bony edema to that central third of the lateral femoral condyle and then the posterior lateral tibial plateau. I'll show you pictures of what we classified as non-classic. And then how often did the radiologist miss this on preoperative imaging? Well, 74% of the time they missed this injury. Here's representative MRI T2 slices. The left side is a coronal image, and you can see evidence of that posterior root tear on the bottom, and then that radial mid-body tear on the top of the screen. And then on the right, those are corresponding sagittal images where you can see a good shot of that radial tear of the body, and then that posterior lateral meniscus root tear. Here's a representative arthroscopic image where you can see that radial tear of the anterior horn body junction and then that posterior root tear. And then occasionally you can get a really good axial slice that captures both of those, which is what you're seeing in the bottom right. So what did non-classic bone bruising look like? So you can see in that first row, that is a single patient. You can see instead of just seeing the posterior lateral tibial bone bruising in that central third of the medial femoral condyle, you're also seeing some medial-sided bone bruising along the tibia. And then in that patient on the bottom, that patient also had medial-sided bone bruising on the tibial side and that lateral femoral condyle side. So in conclusion, these crab tears are underdiagnosed preoperatively, and they're relatively common injury patterns, especially in the setting of adolescents undergoing ACL reconstruction, especially if they're diagnosed with a posterior meniscal root tear, and then especially if they have a higher BMI. If a posterior root tear is identified, the surgeon should be vigilant to make sure they're probing that body, especially that anterior horn body junction that can be sometimes difficult to see arthroscopically. And then future prospective trials examining the clinical significance of this injury pattern are warranted. What's interesting to me is particularly the treatment algorithm in the setting of intact meniscal femoral ligaments, as there's some surgeons who would leave that posterior root tear alone if those ligaments are intact. Thank you so much, and special thanks to Dr. Pennock for the vision of this study.
All right, rounding out the sports medicine section is Dr. Petrie, going to be talking to us about the comparison of re-tear rates and all-cause reoperation rates in pediatric and adolescent ACL reconstruction using bone patellar tendon and quadriceps tendon grafts.
Awesome. Thank you, Dr. Shapiro. So my name is Kyla. I'm one of the fourth-year residents here at UCSF. So we're going to be talking about adolescent and pediatric ACL reconstructions with BTB and quad tendon autografts. So no disclosures from myself or my co-authors. And so background, so kids are kind of continuing along this trend of single sport specialization. They're doing more and more sports year round. And so the rate of these pediatric and adolescent ACL tears has continued to rise, and this has risen at a higher rate than these adult tears. And so unlike the adult population, these young patients who are undergoing this reconstruction are typically faced with a higher risk. That's a higher risk of a re-tear, so closer to 20%, and a risk for growth disturbance with these reconstructions. And so, you know, as more and more people are fixing these tears, the biggest question is always, what is the best graft choice for this population? And so traditionally, hamstring autografts have shown to have a higher failure rate than BTB in this population. Though, again, BTB have kind of been the gold standard graft, and they've kind of been the graft of choice for these higher level athletes. But quadriceps grafts is becoming more and more popular in all patient populations, but especially in this pediatric and adolescent population. But that being said, even though more and more people are using this quad tendon graft, there's really limited comparative data between quad and BTB. And so the purpose of this study was to determine if there are any differences in re-tear rates or reoperation rates between BTB and quad tendon autografts in this pediatric and adolescent patient population. So this was a retrospective study, and so we looked at all of the ACL reconstructions, either with a BTB or a quad autograft between 2013 and 2023 in the senior authors patient population. And so we collected a number of demographic characteristics, so age, gender, graft type, whether or not they played a high-risk sport, they were compliant with the post-operative protocol, and then whether or not they had repeat surgery or if the graft tore. And so our primary outcomes were whether or not the graft tore, if they had a repeat surgery. And then we also attempted to call all the patients afterwards and just try to get more longitudinal data. And again, trying to figure out if the graft retore in a way that wasn't documented in our chart review, if they had a repeat surgery that again wasn't documented, and if they were able to return to sport, and then their IKDC scores. So just kind of basic demographics, our population was about 60% male and about 40% female. We had an average age of about 16 and a half years old, and then about 70% of our patient had a BTB graft, whereas about 30 had the quad autograft. And so our main significant finding was that the BTB graft had about a 5.6% repeat surgery rate, whereas the quad tendon graft had a 1.3% resurgery rate, which again was significantly different. In terms of graft tear, we found that the group and the BTB cohort had a 3.2% re-tear rate, where the quad tendon only had a 0.6% re-tear rate. However, that didn't rise to the level of significance, though there was a fairly small cohort in that group. We also looked at what was associated with re-tear rates. So we found that gender was associated with re-tear. So all those in this cohort who re-tore were male. And then we found that the majority of those who re-tore were not compliant with the post-operative protocol. In terms of our kind of follow-up phone calls, we had an average follow-up of about 6 years. In our phone calls, there weren't any further reports of re-tears that weren't already documented in our chart review. We did find that the graft type, so BTB versus quad tendon, wasn't associated with those who did return to sport. And then finally, we found that return to sport was associated with higher IKDC scores, and that gender approached significance. So there were 70% of the men who returned to sport versus only 45% of the women. And so kind of our big takeaways from this study was there was a higher rate of repeat surgery in the BTB group versus the quad tendon group. And though the graft tear rate was again a little bit higher in the BTB group, that was not significant. And then gender and the compliance with the post-operative rehab protocol was associated with graft tear. There were a few limitations of our study. There were a low number of graft tears overall in this patient population, making it hard to kind of figure out what might have been significant or not. This is also a retrospective study, and then we only were able to get that long-term phone call follow-up from about a quarter of our patients. And then kind of thinking about how this may change practice, again, as more and more people try to use this quad tendon graft, I think this data can kind of inform that decision and let us know that the quad tendon is a viable graft in this adolescent and pediatric patient population. All right, here are references, and then thank you to my co-authors, Pardeep and Dr. Pandya.
All right, thank you. We'll go ahead and open the floor up for questions. If anybody has questions, we have mics we can pass around. Any questions? Yeah.
Great presentations. A quick question for Grant. Do you think if you had looked at the tibia length, that might have been a factor as well that might have predicted outcome? Because obviously patella length would seem to be a cause, especially with a small patella bone, but a large tibia, maybe it doesn't matter. But in my stage of my practice, when I was doing a lot of BTBs, I felt patients complained about pain as much on the tibia side as they did on the patellar side. So I'm just curious, is that something you might look at in the future?
Yeah, I'd love to look at it. I think the problem, we had initially set out to do that. The problem was over half of the MRIs didn't include enough of the tibia. Cut it off too short, yeah. So I think if we could get a longer MRI scan, in the population, that'd be something to really look at, because I think the same, a similar problem happens there. And I actually have a BTB autograph from my knee, and I can attest that I think that there's sort of a kneeling type pain, that you're definitely kneeling on the tibia a lot more, and I think some people are really bothered by that. I think that's a little bit distinct from just kind of general anterior knee pain, which some people feel at the patella. But certainly I think that would be another interesting thing to look at and try to tease out a little bit more with like a questionnaire or something about exactly where the pain is.
For Dr. Petrie, I saw that you had the average graft size for the whole cohort. Did you find any significant differences between the graft size between the two groups? And then did you look at meniscus pathology as well?
Yeah, we didn't actually compare graft size between the two groups, but I would say, again, the majority of the graft size was around that 9 millimeter. There really wasn't a lot of variability. There was a difference in lateral meniscus tear rate between the two groups. So there was a higher rate of lateral meniscus re-tears or reoperation in the BTB group. But yeah, no other differences in meniscal tears or pathology.
I also have a question for Dr. Petrie. I might have missed this in your slides, but were there any significant demographic differences in terms of age, sex, or activity level of sport between the quad and BTB patients?
Yeah, no significant differences. Only the real difference that we found was that almost return to sport rate.
Then I had one question for Dr. Smith as well. I noticed that in the atypical bone bruise pattern, you mentioned that there was also edema of the posteromedial tibial plateau. Did you look at any association between root tears and the crab, or I'm sorry, between ramp lesions and the crab pattern that you identified?
Yeah, we actually did. The crab pattern was not associated with ramp lesions, but there was a trend towards them being associated with a higher rate of medial meniscal root tears as well.
Questions for Grant first. The relative length panned out, but for about absolute length, did you look at that as a separate analysis? Because we don't usually think about absolute length. I mean, relative length, we think about absolute length of graphs. So was the same analysis done and it didn't show significance, or you didn't do the analysis?
Yeah, actually we did the analysis and it was not significant. And so I think that, again, there's such a range in patellar lengths that we found that the proportion is what was significant versus the absolute length was not significant. The only other, we ran all the absolute and relative numbers, and the only other one that was absolute was that residual defect depth at 1 year, and that was only in the category of pain.
Okay, thanks. Dr. Petrie, in Dr. Pandya's practice, has it evolved over time where his early cases are BTB and his later cases were quad? And if that's the case, then how would you interpret the data based on compensating for increased experience over time?
Yeah, I think that's a good question. His cases definitely have evolved over time. The majority of his initial cases were done with BTB, and his more recent cases have been primarily quad. So I think you make a good point that, obviously he's become more experienced and has been doing this for a lot longer. And so there may be a portion of experience in that.
Dr. Smith, just a comment. When you see your mentor, tell him hi from Hubert Kim, because he actually was in my lab way back in the day. I mean, it was decades ago, but that's part of that, the circle of life thing, seeing people, younger trainees, doing research, and then later having that impact on the next generation. So OREF has been a wonderful source of support and funding for that continuous contribution to multiple generations of orthopedic research.
Awesome. I'll tell him you say hi.
Thank you.
For Dr. Petrie, great presentation. A question about sort of the graft size. The sagittal width of a BTB is typically maybe 3 to 4 millimeters, whereas the sagittal width of a 9 millimeter quad is kind of 9 by 9, and so it's a much more significant amount of collagen in quad tendon versus a BTB because of that reason. I noticed you mentioned your tunnel. I think the average was 9.2 or something like that, because we size our quad tendons by the size of the soft tissue. We size our BTBs by the size of the bone plug that's going to pass, and so we frequently say it's a 9 millimeter BTB, but it's actually probably 3 by 9 millimeters versus 9 by 9 if you want a quad tendon. Do you think that volume of tissue gives you a much stronger graft, and maybe that explains why you have a lower failure rate?
Yeah, I think certainly possible. I think there has been more research, especially in female athletes, that the kind of getting to that 9 mm graft size is really associated with a lower retear rate. So I think that is really important, probably in these younger athletes as well.
Excellent. Thank you all. We'll wrap up the sports section and we'll hand it over to Dr. Swarup for arthroplasty.
Perfect. So, excellent job, everybody. So starting off session 2, we're going to talk about arthroplasty. The first presenter is Dr. Gardner from the San Francisco Orthopaedic Residency Program, and they'll be talking about specific patterns of anterior acetabular cystic change in the absence of other degenerative changes, a potential clue for occult instability, especially in borderline dysplasia cases.
Good morning, everybody. My name is Carson Gardner. I'm a fourth-year resident with the San Francisco Orthopaedic Residency Program out of UCSF St. Mary's. This morning I'm going to be talking about specific patterns of anterior acetabular cystic changes in the absence of other degenerative changes, a potential clue for occult instability, especially in borderline dysplasia cases. I want to begin by thanking my co-authors, Dr. Zmug over at Kaiser in Oakland, who really kind of led this study for us, and then Dr. Shapton and Dr. Irva, my co-residents, who helped out as well. None of us have any relative disclosures or conflicts of interest. I'm going to start with a little bit of background. We know that hip arthroscopy is an effective treatment for femoroacetabular impingement. It has good long-term outcomes in the treatment of FAI and labral tearing at the hip. A 2019 meta-analysis in AJSM of about 1,900 patients showed 87.7% return to sport. All the patient-reported outcome measures they looked at in that study improved postoperatively, but there's still this 5.5% rate of secondary surgery, which begs the question, why do these 5.5% fail or need another surgery? Well, to begin to answer that, or try to answer it, we know that hip arthroscopy is also of questionable efficacy in isolation in dysplastic hips. So isolated hip arthroscopy does not address structural acetabular dysplasia. Numerous studies have demonstrated inferior outcomes with dysplastic hips with a lateral center edge angle of less than 20. More recently, some literature has pointed to isolated hip arthroscopy being effective in borderline dysplasia and in quote-unquote well-selected patients. So how do we select patients well? And how do we know when the borderline dysplastic patient with an LCA of 20 to 25 is going to do well with an isolated hip scope? Well, it's a really challenging question that hip arthroscopists face in their clinics on a regular basis. And so we're always looking for clues of instability. So the cyst pattern you see here is the cyst pattern in question that we found. It's more medial, a little bit more anterior than your typical paralabral edge loading cysts. And it's importantly consistent, it's unique, and it's seen without any other degenerative changes. So you can see the arthroscopic image on the right, which shows well-preserved cartilage throughout that acetabulum with the exception of that one spot where there's that cyst. And so this led to some questions about why that cyst forms. So we sought to describe a unique and consistent pattern of acetabular cystic change in the absence of other degenerative changes in a series of patients with borderline dysplasia that may be suggestive of occult instability. We retrospectively reviewed patients noted to have this specific cyst pattern. We collected demographic, radiographic, and clinical data on each patient. We excluded hips that had other signs of degenerative changes, and we defined borderline dysplasia as a lateral center edge angle between 20 and 25. So what did we find? There was 41 hips in 31 patients. 36 of those met our inclusion criteria. 25 of them were female and 1 were male. They had an average age of 32.3 years. Of these 36 hips, 12 of them had borderline dysplasia with a mean lateral center edge angle of 22.4 degrees. Of those 12 borderline dysplastic patients, 4 of them ended up having an isolated hip arthroscopy. And all 4 of those patients went on to a future PAO as a secondary surgery because they had persistent pain. So when we look at this table comparing our isolated hip scopes versus our hip scope plus PAO cohort, obviously a limitation of our study is that we had relatively low numbers, so none of these values are significant, but there is a trend. I'll draw your eye to 2 things here. The first is age. The isolated hip scope patients were on average about 6 years younger, and it was approaching significance. And the anterior center edge angle was also about 3 degrees higher in the isolated hip scope group at 28, which is within the normal range for anterior center edge angle, which makes you wonder, these are all, it's a single surgeon study, these are all Dr. Smug, is that having the anterior center edge angle within the normal range pushing you more towards doing an isolated hip scope versus including the PAO with it, as well as being a younger patient. So in conclusion, patients with borderline dysplasia present a challenging clinical decision regarding the correct course of treatment. This isolated cystic change, which we described in this study, may be a useful indicator of instability in patients without other overt signs of hip dysplasia. And these patients may warrant a treatment algorithm that involves reorienting periacetabular osteotomy in addition to just a hip arthroscopy. Thank you.
All right, thank you, Dr. Gardner. Next up is Dr. Crawford, who will be presenting on risks for reoperation to promote union in periprosthetic distal femur fractures.
All right, good morning, everybody. My name is Ben Crawford. I'm a fifth-year resident at the San Francisco Orthopaedic Residency Program, now UCSF St. Mary's. Going to be presenting on risk factors for reoperation to promote union in periprosthetic distal femur fractures. To provide some background, as the rates of total knee arthroplasty increase, so coinciding are periprosthetic distal femur fractures. The incidence of these fractures is ranging from around 0.3 to 5.5% in primary TKA, and much higher, even up to 38% for revision TKA. The management of these fractures is difficult due to poor bone quality and limited fixation options, and reoperation for non-union is a significant complication and difficult to treat. So the purpose of this study is to determine risk factors for reoperation to promote union in these periprosthetic distal femur fractures. In our methods, so it's a multi-center retrospective cohort study. This used the NorCal Kaiser database, and the selection criteria were patients with periprosthetic distal femur fractures. And to note, this was with a single lateral locking plate. These were all reviewed. And data points include demographics, medical comorbidities, injury and fracture characteristics, type of fixation, and then details of the construct used. Our exclusion criteria were any fractures that are acutely managed with a DFR, and then any constructs that were involving an intramedullary nail or dual plate construct. And then we required at least 6 months of follow-up, and of course, lack of imaging. And again, the primary outcome was measurement of reoperation to achieve bony union. In our results, 68 patients were screened, 52 patients met inclusion criteria. 7 patients of those 52, which is 13.5%, required a reoperation for union. Baseline demographic data, there was no differences in age, sex, BMI, comorbidities, or the SU classification. For those of you who may be unfamiliar, it's essentially the level of the fracture line relative to the anterior flange of the femoral component. And unsurprisingly, the majority of these fractures were low energy ground level falls. Again, so further into our results, what we found to be significantly associated were notching preoperatively, number of independent screws through the fracture line. These screws were placed outside of the femoral plate. Plate length less than 12 holes, and then also proximal screws that were locking. And also to note, there was also an association, but not clinically significant, with the amount of distal screws as well, with fewer screws being more protective. So the clinical implications of our study to kind of guide the surgeons on their planning for their fixation construct for these fractures. To optimize this, we recommend using plates that are greater than 12 holes, avoiding independent screws through the fracture line. You may consider more proximal locking screws, considering a lot of these patients are very osteoporotic with poor bone quality. And then particularly with those patients with very low fractures or limited bone stock, you may want to consider dual plating and nail plate combos, for which a lot of current research is being done. And in terms of prevention, by avoiding femoral notching during the primary TKA, we believe that this may be a protective effect. And this relates to our hypothesis that femoral notching may lead to a lower fracture pattern, providing the surgeon with less bone stock for their final fixation construct after these fractures occur. In summary, this is a fracture pattern that is fairly rare, but is becoming more common, with around 13.5% non-union rate or rate of reoperation with lateral locking plate in our study. This matches a lot of the current data as well. Risk factors we found to be preoperative femoral notching, screws through the fracture line, shorter plate lengths, plates less than 12 holes, and fewer proximal locking screws. So the surgeon can use this information to kind of guide their fixation construct when they're managing these fractures. And that's all. Thank you so much.
Thank you. Next is Dr. Nwachuku, who's going to be presenting on osteoarthritis and total joint arthroplasty in housing insecure patients at a safety net hospital in a major urban city.
Okay, good morning, everybody. My name is Kelechi Nwachuku. I'm a fourth-year resident here at UCSF. Just wanted to thank you all for the opportunity to present our study centered around total joint arthroplasty in housing insecure patients. I or my co-authors have nothing to disclose. So for some background, as many of us know, osteoarthritis is the leading cause of disability among older adults in the US. To add, people experiencing homelessness, abbreviated PEH here, are disproportionately impacted by it. The rate of arthritis among homeless patients is reported to be between 20 and 45% compared to 7% in the general population. Something else noteworthy is that 41% of homeless adults report difficulty walking. Now, even though those homeless suffer from osteoarthritis at higher rates, they've been shown to access orthopedic care at disproportionately lower rates. As of 2023, only 2 studies examined outcomes of total joint arthroplasty in homeless patients, both being retrospective cohorts. They've shown that even though homeless patients had higher 90-day ED returns, they had similar rates of readmission, reoperation, and PJI compared to the general population. Moreover, they found no surgery-related reoperations or readmissions and a 75% improvement in housing status at 1 year post-op. So to further assess the relationship between homelessness, arthritis, and its care and outcomes, the primary objective of our study was to examine surgical outcomes after total joint arthroplasty among those experiencing homelessness and housing insecurity. We hypothesized that while people experiencing homelessness and housing insecurity may have higher ED utilization post-operatively and lower rates of post-op follow-up, there will be no differences in readmission or reoperations. The secondary aim was to compare the rate of presentation for evaluation between unstably housed and housed patients and to assess where in the care provision process barriers existed. We hypothesized that those experiencing homelessness would be less likely to present to clinic for evaluation than stably housed patients. We designed a retrospective cohort study that examined all new patient visits to the San Francisco General Hospital Arthroplasty Clinic from 2022 to 2023. We collected various demographic data and performed our analysis on 2 cohorts, one that was housed and another that combined both marginally housed and those homeless in an unstably housed cohort, with there being a low number of truly homeless patients. For the secondary analysis, the proportion of those experiencing homelessness who presented to clinic over the estimated number of homeless in the hospital catchment area was compared to the number of patients who presented to clinic who were on the SF health plan over the total number enrolled as a proxy for the stably housed. As the primary safety net hospital in San Francisco, we assumed that most unhoused patients who needed to access arthroplasty services would seek care at the general hospital. Moving on to the results. As far as demographics, patients in the unstably housed groups were younger, more likely to be male, and more likely to be Black or white. Patients in the unstably housed groups had higher rates of substance use, HIV, mental illness, and higher KL scores at their initial visit. There were no significant differences in progression to surgery, number of injections received, follow-up attendance, 90-day ED visits, 90-day readmissions, and 1-year revision surgeries between the two cohorts. Our secondary results demonstrated that people experiencing homelessness were 5 times less likely to present to clinic for initial evaluation compared to house patients. Limitations included significant demographic differences between the cohorts, a small sample size, and possible incomplete capture, with some homeless patients potentially treated at other sites. So in conclusion, there were no significant differences between those housing insecure and secure patients in postoperative ED utilization, surgical outcomes, and attendance at follow-up appointments. PEH presented to clinic at disproportionately low rates when compared to house patients. So overall, these findings suggest that total joint arthroplasty is a safe and effective option for those housing insecure who face a high disease burden and barriers when accessing care. These results represent an important first step toward addressing disparities in musculoskeletal care and identifying opportunities to improve access and equity in surgical treatment for vulnerable populations. Here are my references. Thank you to my co-authors.
Thanks, Dr. Nwachuku. Next up is Dr. Pius from Stanford, who will be presenting on navigated and robotic total knee arthroplasty do not confer improved 5-year survivorship compared to conventional total knee arthroplasty.
Hi, good morning, everyone. Thank you to the OREF for hosting. I'm Alexa Pius. I'm from Stanford, PGY4, and I'll be presenting our research on computer navigation and robotics and midterm outcomes after primary total knee arthroplasty. This is an analysis from the American Joint Replacement Registry. These are the disclosures of my co-authors. The use of navigation robotics has increased significantly by 20% over the last several years. The benefits of this advanced technology are improved component position, reduced alignment outliers, and potentially improved patient outcomes. But the question remains, does improved component position result in improved implant survival? So the purpose of this study was to compare the midterm implant survival of computer navigation used in primary total knees and robotic total knee arthroplasty to that of conventional instrumentation using the American Joint Replacement Registry. The database was queried for all primary total knee procedures between 2017 and 2022 for patients over 65. The final cohort contained 174,000 patients, 28,000 of which were navigated, 22,000 were robotic, and 131,000 were conventional total knee arthroplasty. ANOVA testing was performed for multiple comparisons, and chi-square analysis was used for categorical variables. Standard Cox proportional hazard models were used to generate the percent revision curves and the hazard ratios, and these were adjusted for age, sex, fixation type, and year of procedure. At the 5-year follow-up time point, first we're going to compare robotic versus conventional total knee arthroplasty. There was 22,000 conventional total knees and 1,165 robotic total knees at the 5-year follow-up, and there was no difference in all-cause revision, with 2.06% in robotic and 1.98% all-cause revision in the conventional group. The hazard ratio for this was 0.97 with confidence intervals of 0.84 to 1.13. Moving to mechanical loosening, there was also no difference in mechanical loosening at 5-year follow-up between the groups. The hazard ratio is 1.2 with confidence intervals of 0.73 to 2.07. And similarly, there was no difference in other mechanical complications between the two groups, with 0.3% in robotic and 0.27% in conventional. And that information again presented in graphic form showing hazard ratio of 0.83. Now moving on to the navigated versus conventional comparison. At the 5-year follow-up time point, there was 22,483 conventional and 3,343 navigated knees in the cohort. And again, there was no difference in all-cause revision at 5-year follow-up, with 2.07% in navigated and 1.95% in conventional. This information again in the graphic form showing a hazard ratio of 0.93 with a confidence interval of 0.81 to 1.07. Likewise, we found there was no difference in mechanical loosening at the 5-year follow-up time point. And there was a significantly fewer amount of navigated total knees that had other mechanical complications compared to the conventional at the 5-year follow-up time point, with 0.14 cumulative revision risk compared to 0.31% with conventional total knees. The hazard ratio for this was 0.44 with a confidence interval of 0.25 to 0.77. The limitations of this study are the coding errors that are inherent in a large database study, the fact that it only included patients over 65 years of age. It's limited to the institutions that supply data to the AJRR, and age, sex, year, and fixation were the variables that were included in our model. The strengths of this include the cohort size and the fact that we did have 5-year follow-up on a significant portion of these patients. So in conclusion, I think the AJRR data does not demonstrate improved midterm implant survival when using computer navigation or robotics compared to conventional instrumentation. I think this information is important when we're counseling our patients and to guide that discussion. And I also think it will be interesting to see what the longer term follow-up will be at 10, 15, or even 20 years post-op. Thank you.
Thanks, Dr. Pius. Next up is Dr. Shapton from the San Francisco Orthopaedic Residency Program, who will be presenting on metal femoral heads do not increase serum metal ion compared to ceramic femoral heads.
Perfect. Hi, everyone. I'm John Shapton from St. Mary's. I'll be presenting today on metal femoral heads do not increase serum metal ions compared with ceramic femoral heads in primary total hip arthroplasty. So trends in primary total hip arthroplasty indicate there's a growing preference towards ceramic heads over metal femoral heads in these primary surgeries. This utilization disparity is driven in part by concerns over metal wear in metal on polyethylene bearings, an issue which is less prevalent in ceramic on polyethylene bearing surfaces. So as the field of arthroplasty continues to prioritize cost effectiveness and personalization in surgery, distinguishing implants based on their costs and their available sizing options is essential. So in the majority of practice settings, ceramic femoral heads are more expensive than their metal counterparts. Metal femoral heads additionally often offer more sizing options, so they have more options in femoral head size and femoral head length. And so having these more sizing options may help facilitate anatomic reconstruction of the hip with resultant improvements in stability and range of motion. Research comparing serum metal ions between metal on poly and ceramic on poly bearings is relatively limited at this time, especially at midterm follow-up. So we performed a retrospective review of patients who underwent primary unilateral total hip arthroplasty between 2015 and 2017 at a single hospital within the Kaiser Permanente system. All patients received a primary total hip arthroplasty with metal on poly or ceramic on poly bearings, had a minimum follow-up of 5 years from the index surgery, and underwent serum assessment of cobalt and chromium levels after their index surgery. All patients received an uncemented femoral stem and a ceramic or cobalt chrome femoral head coupled with a highly cross-linked polyethylene liner. Serum ion levels, specifically as important for this study, we're looking at cobalt and chromium, were evaluated greater than 5 years after the index surgery. Of note, these laboratory values were being routinely collected at this time period. So we hypothesized that there'd be no difference in serum metal ion levels between the ceramic on poly and metal on poly implant groups. With an alpha level of significance set to 0.05 and a power level set to 0.8, a sample size of 44 patients in each cohort was necessary to detect significant differences between the two groups. So a total of 110 patients met the inclusion criteria and were evaluated in this study. There were 58 patients who received metal on poly bearings and 52 patients who received ceramic on poly bearings. The mean follow-up was 5.8 years with a range of 5 to 7. Patients in the metal on poly group were younger, but otherwise demographic variables were found to not be significantly different between the two cohorts. So with respect to chromium of 58 patients with a metal on poly bearing, 91.4 had detectable chromium levels. Detectable levels at our institution is greater than 0.1 micrograms per liter, compared to 84.6% in the ceramic on poly bearing group. In the metal on poly group, the average serum chromium level was 0.26 compared to 0.20 in the ceramic on poly group. When assessing the serum chromium levels, 43.1% of patients in the metal on poly group had detectable chromium levels compared to 26.9% in the ceramic on poly group. In the metal on poly group, the average serum cobalt level was 0.24 compared to 0.17 in the ceramic on poly group. Additionally, the metal on poly group had a cobalt to chromium ratio of 2.6, while the ceramic on poly group had a mean ratio of 3.9. When comparing these patients against a threshold of 1.4, this has been established in the literature. 74% of patients in the metal on poly group had elevated cobalt chromium ratio compared to 92% in the ceramic on poly group. So essentially what we found is that at final follow-up at a range of 5 to 7 years, there was no statistically significant difference in serum cobalt or chromium between patients with metal on poly or ceramic on poly bearing surfaces. All patients had serum cobalt and chromium levels well below the established safety thresholds. And although cobalt and chromium ratio greater than 1.4 is commonly used to help diagnose adverse local tissue reactions, this number comes primarily from metal on metal hip replacements. No cases of adverse local tissue reaction from metallosis were identified in our cohort during this time period, despite many patients in both cohorts exceeding this ratio. Something else to consider is we did find elevated cobalt and chromium in our ceramic on poly group without a true metal on metal articulation. Patients should not, in theory, have this elevated cobalt and chromium. So it calls into question the lab value or looking for alternative sources for these elevated labs in these patients. So the main takeaway in this paper is that patients undergoing primary toe-lip arthroplasty with metal on poly bearings did not exhibit a significantly higher cobalt or chromium ion levels than those with ceramic on poly bearings at 5 to 7 years of follow-up. So this difference in metal ion production may be clinically inconsequential when comparing metal on poly and ceramic on poly bearing surfaces. Thank you.
All right, thank you all for those excellent papers. The paper is now open for discussion. Are there any questions? As questions are coming up, but we'll start with, for Dr. Gardner, you talked about cystic changes in the acetabulum. Did you also look to see for concomitant changes in the labrum, so labral hypertrophy, labral tears, and additionally, did you look at like tonus grade as well on X-ray, whether those were correlated with those acetabular-cystic changes on CT or MR?
So we didn't record in an objective way labral tearing or hypertrophy, but all of these patients I think had some degree of labral tearing and hypertrophy as part of their indication for getting the hip arthroscopy to begin with. We just didn't objectively measure that. And we also didn't objectively measure the tonus angle. We looked at lateral center edge angle and anterior center edge angle only.
Dr. Nwachuku, that is a great talk. I have a question about your study. You had mentioned that the patients had a 5x rate of presenting to clinic at a lower rate, right?
Yes.
How does that compare to other conditions outside of knee or hip OA? Do you have a sense of that?
That's a great question. Just to reiterate, it sounds like you're asking how does the, I guess, disproportionately lower rate of presentation to clinic in OA compared to just other diseases?
Exactly.
That's a great question. I would have to look through the literature. But what I can imagine, though, is that it would probably mean, for hip and knee arthroplasty, it's a very debilitating condition, but a lot of the patients also had other comorbidities that took precedence. So I'd imagine that and in other diseases, they probably present at like higher rates, but I would have to review the literature to give you a definitive answer.
Got it. And did you guys look at length of stay at all or other healthcare resource utilization after surgery?
Yeah, great question. We didn't look at length of stay in terms of, or like that wasn't a focus of our study, but what we do know is that there is just higher rates of healthcare utilization for the homeless population, longer stays in SNF, and things of that nature. But surprisingly, in our study, contrary to other studies, there wasn't a disproportionate rate of like readmission or utilization.
Got it. Thank you.
Of course.
Dr. Pius, question for you. Nice study. Are you surprised by the results of what you found? And also, what are some of the reasons that you think you did not find a difference between robotics versus conventional?
Yeah, I'm not surprised. I think the question that people still talk about is we don't know what makes a good total knee replacement. And so I think this kind of reflects that whatever manner you're using that, whether it's navigation, robotics, or conventional, there's not a significant difference in that midterm follow-up. I think the hope would have been that, if we're more precise with our cuts, then we follow our template better, then we might have improved outcomes. The fact that we didn't see that, I think, points to that underlying question that remains unanswered.
Thank you. And just a quick follow-up question. Do you have any data on surgeon experience or number of joints a year that was in the database?
That is recorded in the database, and I don't know the answer of the breakdown between those, but I think that's a really important factor to pay attention to. Another thing I just wanted to comment on is I think the surgeon user experience is also a big factor of that, and so I think for better or for worse, the technology is here to stay, and whether that's because surgeons enjoy using it or because patients are asking for it. I think it's something that's here to stay, but I think when we see patients in the clinic and they're asking about these technologies, it's important to be accurate with the data that we're providing them.
Thank you.
Question for Dr. Crawford. Question about, the notching is one of the primary factors. Can we get ahead of this upstream, and can we prevent notching?
Yeah, I think that's an interesting point, and in terms of course, being the controllable risk factors for the trauma surgeon or treating surgeon at the time, that's not within that realm. But in terms of treating, recommending to the arthroplasty surgeons, it can be difficult to prevent that intentionally. Of course, that's a goal to avoid, but I think it's being more mindful of that and realizing that that does increase your risk of fracture following the primary TKA. So in terms of prevention, I think that's an important tool, and that's something to consider for sure.
And a follow-up for you, Dr. Crawford, you kind of alluded to this a little bit. What do you think is the ideal construct for these types of fractures? Is it, longer plates, bridge plating, like relative stability, or is it more, dual plating, more rigid construct? What's ideal?
Certainly. I think like a lot of trauma, the answer might be that it depends on the fracture pattern, the patient characteristics, where the fracture extends and how distal. I think our study shows that a single lateral locking plate can be fairly effective, and particularly in those fracture lines that exit proximal to the anterior flange of the femoral component are more amenable to kind of a bridge plate type construct, a long plate spanning the fracture zone. And then our recommendation is for lower fracture lines with lower blown stock, you may need to consider more than just that single lateral locking plate, and that's where a lot of the current literature is recommending dual plate constructs or plate nail combos. So I think the answer is that it depends, but there are a lot of options that we have available nowadays based on the fracture in the patient.
literature
So the notching was defined, so that was an interesting finding that we had in our study. And like I mentioned, our hypothesis is that preoperative notching can result in a lower fracture line with these periprosthetic fractures that will then maybe increase your rate of reoperation. We defined notching based on the preoperative images that we had, often CT scans, by seeing where that anterior cut, a distal cut, would exit. And if you had notching there, then that was included in the study.
Just to get clarification on that, so, you know, in arthroplasty, where we think of a notch as a cut that goes and you're kind of inside that cortex and there's a little step, right? Whereas we tend to accept an arthroplastic cut that goes beyond where the top of the anterior flange ends. And if it's a smooth transition, we don't call it a notch. Later on, if you go back and see in revision knees, it remodels a little bit. And so what could have been what we wouldn't call a notch in arthroplasty then looks like a notch later. So how were you able to distinguish between those scenarios? You know, if so, how did that affect the outcomes?
Okay, yeah, I understand the question. So we didn't have objective criteria that we used to define the notching prior, and just like you mentioned, having that step cut where you're going into that anterior femoral cortex. So based on our reviewers, it was more of a subjective definition of what they thought, and that could lead some variability in those findings, certainly.
Question for John. For the source of metal ions in the ceramic cases, is the trunnion or perhaps the stem of the device itself, it's a micromotion there, maybe the source of?
So yeah, I mean, it's something when we initially saw this value, or these values, we didn't think that we'd see the elevated levels in that group. We were primarily using a stem that had a titanium trunnion. So theoretically should not have cobalt and chromium that can be eluted into the blood from there. So we did look at it a little bit more and started doing some analysis to see if maybe different supplements or other factors could come into play, but we haven't been able to elucidate anything from that yet.
All right, well, thank you all again for excellent group of papers, and we'll have about a 10-minute break now.
We're going to go ahead and get started with our next session. All right. We're going to get started with our next session. If everyone can please take a seat. All right. Hopefully that was enough of a break for folks. We're going to start the spine session. First up is Stephanie Chang, going to talk to us about perioperative bleeding complications of vertebral body resection in patients with and without a prior spine infection.
Where's the presenter view on this? I'm struggling. Play from start. Beautiful. All right. I'm Stephanie. I'm one of the PGY3s at St. Mary's. I'll be talking about perioperative bleeding complications of vertebral body with and without prior spine infection. So a little bit of background. Resection of the vertebral body is a tool that is often used to treat a variety of spinal conditions. It can be used to help facilitate curve correction in the setting of spinal deformity. It can also be used, for example, like a corpectomy to remove any infected bone in the setting of osteomyelitis. And it can also be used during bony tumor resections in the setting of spine tumors. So compared to just a posterior column osteotomy, partial or complete resections of the vertebral body can result in a greater amount of blood loss and bleeding complications just due to the significantly greater vascularity of the vertebral body. Other things to note is that spinal infections are also noted to have a higher risk of perioperative complications and mortality.
There's wondering if this is because that they have more vascularity in the setting of infection. So the purpose of the study was to get a better understanding of perioperative complications between active infections, prior infections, as well as non-infectious spinal pathology, just to help surgeons better safely manage and counsel patients. Our hypothesis is that vertebral body resections for an infectious spinal pathology would lead to greater blood loss, 48-hour drain output, just due to the potential vessel scarring, alter anatomy, as well as the inability to use blood salvage in these procedures. We also looked at transfusion times, operative times, as well as hospital length of stay and non-neurological complications. So methods, this was a retrospective database study by a single senior spine surgeon at a teaching hospital. We looked at his cases from 2007 to 2023. A total of 42 eligible patients were selected, and of these, 16 of these patients had non-infectious spinal pathology, 10 had a prior infection of resolved osteomyelitis, and 16 had a current active infection. Some of our exclusion criteria were just age and a pathology due to fracture, malignancy, and rheumatoid. And then we also were able to use the spine surgical invasive index to kind of help match our cohorts. So from the results, just looking at patient parameters, we looked at their medical history from coagulopathy, diabetes, alcohol, drug use, CKD, hepatitis, as well as chronic steroid use. Average age across all groups was around 64 years old. We did know that there were more male patients in our prior infectious group at 72% compared to our no infection, which was at 31%. Our active infection group also had a higher history of alcohol use at 56.2% compared to our non-infectious and prior infectious groups. Our basic labs, albumin, platelets, and INR were pretty unremarkable, except for the fact that platelet counts were lower in our no infection group. Looking at our perioperative data, the highest surgical invasive index was in our no infection group at 21.47 compared to our non-infectious and prior infection group. Our active infection group had the highest Schwab osteotomy grades, as we did usually do a corpectomy for these. Our non-infectious group, on the other hand, had the higher number of instrumented levels. Otherwise, there are no differences in our average operative time, blood transfusions, or blood loss. What we did note was the 48-hour drain output was highest in our no infection as well as our prior infection group, while it was the lowest in our active infection group, which was definitely different from what we were predicting. The hospital length of stay is the longest in our active infection group, likely due to the use of IV antibiotics. When we kind of used a one-way ANOVA to match these three groups using the surgical index, we found that there were significant differences in EBL, 48-hour drain output, as well as the Schwab osteotomy. EBL was highest in our no infection, and 48-hour drain output was higher in our prior infection group. So in conclusion, our no infectious cohort demonstrated the highest amount of EBL. They had the highest surgical invasive index, overall operative time, as well as the greater number of instrumented levels. Our prior infection group ended up having the highest 48-hour drain output, and our active infection had the greatest length of stay. The other, I guess, things that we looked at had shown no significant differences. And thank you. That's it.
Thank you. Next up is Dr. Woodard, talking to us about reciprocal changes in sagittal spinal alignment are similar after L5-S1 and L4-S1 anterior lumbar interbody fusion.
All right, thank you. Good morning, my name is Thad. I'm one of the PGY4s at UC San Diego, and today I'm going to be talking about sagittal alignment changes after distal lumbar interbody fusions. So background here, anterior lumbar interbody fusions will be referred to as ALIFs moving forward, are powerful tools for treatment of distal lumbar pathology. Some of these include neuroforaminal stenosis, degenerative disc disease, spondylolisthesis, and obviously other pathologies. They can be used for correction of sagittal alignment in degenerative settings, especially in the adult spine literature. Correction of sagittal relationships is one of the most important things for improving patient-reported outcomes, as well as decreasing hardware complications, need for repeat surgery. However, within spine literature, sagittal alignment and sagittal relationships is constantly evolving, with new papers coming out every 5 to 10 years. So as people are planning for correction, we have to be really mindful about what the unfused segments are going to do, so that long term, when the targets are changing, that we still have something that resembles an adequate curve in the lumbar spine. Currently, there's limited data that exists regarding compensatory changes in the non-fused segments in the proximal lumbar segments following ALIFs, and this creates a problem for surgical planning. So the purpose of this study was to look at the segmental and global lordosis changes within the lumbar spine following ALIF procedures, and we hypothesized, kind of as expected, that we would have an increase in segmental lordosis following ALIF procedures, as well as having global lordosis changes defined by as L1 to S1 following ALIFs. For methods, we looked at preoperative and postoperative 3-month sagittal radiographs that included both the hips to all of the lumbar spine of primary lumbar spines from multiple spine trained surgeons. We excluded all patients that got posterior column osteotomies and who didn't follow up for more than 3 months. We did sagittal alignment measurements listed here, including a 1-to-1 lordosis defined here as LL, 1 to 4 lordosis, 4 to 1 lordosis, 4 to 5 lordosis, 5 to 1 lordosis, as well as lumbar distribution index, which is defined as L4 to S1 lordosis divided by 1 to 1 lordosis. We also looked at pelvic instance and pelvic tilt. We also measured the preoperative and postoperative disc angles at the instrumented levels, both L4-L5 and L5-S1. We also measured the implant lordosis for each of the ones that were implanted at instrumented levels. We then ran simple one-sample t-tests and did linear regression analysis around the L5-S1 level. In terms of results, we identified 85 patients, the majority of which are male. We had a pretty split cohort between 1-level and 2-level fusions, and an average PI of around 52 degrees. Across the entire cohort, there were significant increases in 4 to 1 lordosis of about 7 degrees, with the majority of that increase in lordosis coming from 5 to 1 of about 6.5 degrees. The lumbar distribution index also increased it by about 10, which I can explain later. There were significant decreases in the 1 to 4 segmental lordosis by about 3.7 degrees, and pelvic tilt decreases, which is a good thing. There's no significant change, however, in the global lumbar lordosis, and nor the PIL mismatch, because the overall lumbar lordosis didn't change, and there was no change across the cohort for 4-5 lordosis. So we substratified our patients into patients undergoing 5-1 surgeries and all the way from 4 to 1. There was no significant difference between these two cohorts in terms of their preoperative measurements. Postoperatively, 4 to 1 patients had greater changes in 4 to 1 than 5 to 1 patients. They got roughly 3 more degrees and an increase of lordosis. Notably, however, the 4 to 1 patients gained segmental lordosis at 4-5, whereas the 5-1 patients actually lost lordosis at 4-5 as a compensatory change following the addition of lordosis at 5-1. There was no significant difference between the two cohorts in terms of their overall change of lumbar lordosis. There was no difference in the change in 1 to 4 lordosis, and there was no, when I compiled the 5 to 1, 4-5 change to the 1 to 4, the overall unfused segments didn't have a difference between the two cohorts. There was also no difference in the change in pelvic tilt, 5-1 segmental lordosis, nor the change in lumbar distribution index. I pooled all the 5-1 patients, so both the 4-5 patients and the 5-1 patients. We excluded the 3 patients who went 4-5 ALIFs into an 82 patient cohort for linear regression analysis. And what we found was the change in the 5-1 disc angle actually predict moderately well the change in the lordosis at 5-1 for the terms of the segmental lordosis with a R-squared of 0.57. However, the actual implant lordosis poorly predicted the segmental lordosis at that level and the actual disc angle. And here's an example of one of our patients who underwent the surgery from 4 to 1. So in conclusion, segmental lordosis gains that are achieved in the distal lumbar spine following 4 to 1 and 5 to 1 ALIFs are offset by loss of lordosis in unfused proximal segments following distal lumbar ALIFs. This led to no global change in lumbar lordosis, but caused a redistribution of the lordosis to being more in the distal lumbar spine. This is thought to be a positive change within the adult spine literature, especially in the context of correction of degenerative deformity. Change in the disc angle at L5-S1 was correlated with the segmental lordosis change at that level. However, the actual implant lordosis was poorly correlated with the postoperative segmental lordosis and the disc angle itself. I think this highlights how hard it is to plan for these surgeries, that even if you stick an implant in, you say, I have a 15-degree cage, you're not necessarily going to get a 15-degree lordosis at that level, which again, complicates surgical planning. Why I think this is important is you can look at the preoperative disc angle and say, the preoperative disc angle is 5 degrees, I'm putting in a 15-degree cage, I think I can get 10 more degrees lordosis, and that was relatively reliable. Overall limitations, we only had 3-month follow-up. These were isolated distal lumbar fusions, and this is a retrospective cohort study with limited sample size. But I do think it shows the concept that we need to be really meticulous in our surgical planning and to anticipate the changes proximally as we're setting these people up probably for another surgery down the line, that we can limit the surgery that we have to do. Thank you so much.
Thank you. All right, next up we have Dr. Olson from UCLA. Comparative analysis of postoperative outcomes in type 1 versus type 2 diabetes patients undergoing spinal fusion.
All right, thank you. I'm Thomas Olson from UCLA. This is comparative analysis of postoperative outcomes, type 1 versus type 2 diabetes in spinal fusion. So starting out with some background, we all know that diabetes is a leading independent risk factor in orthopedic surgery, all orthopedic surgery, not just spine. Over 15% of the population is impacted by diabetes, and we know that it has impacts on wound healing, immunity, and bone health. Overall, across all specialties, it's known that there's a 2 to 5 times higher risk of infection after orthopedic surgery with a comorbidity of diabetes. However, standard risk models treat all diabetes the same. Most of this is focused on hemoglobin A1C, which is used as a surrogate for diabetic control. A lot of studies have shown that a higher hemoglobin A1C is associated with a higher infection risk. But these treat diabetes all under one umbrella, and these diabetic patients are not all the same. Some emerging literature has come out, especially in our most studied specialty of total joints, showing that A1C might not be an adequate indicator of risk. Finally, a study came out recently that is the only one I know of in existence that looks at the difference in type 1 and type 2 diabetes, and showed for the first time in total knees and total hips that there's a higher risk factor for infection in type 1 diabetics as compared to type 2. We sought out to look at the same thing in spine surgery. So we did a retrospective database study looking at type 1 and type 2 diabetes using ICD and CPT codes, and then we matched these patients using propensity scores on demographics, comorbidities, diabetic control, and procedure type. We came up with 1,261 matched pairs, and we looked at their postoperative outcomes 1 year following surgery, which included things like infection, readmission, reoperation, fracture, gait abnormality, and mortality. What we found is that across the board, type 1 diabetes had a higher risk. For infection, it was nearly 3 times as high, 3.4% versus 1.2. Same thing for readmission, reoperation, fracture, and mortality. The only things we didn't see differences in were weakness and sarcopenia, as well as dorsalgia, or posterior spine pain. These relationships persisted on survival analysis. And we went one step deeper to look at if this differed between cervical and lumbar regions. So we repeated the same thing. Slightly smaller cohorts, 467 in our cervical group and 257 in our lumbar group. For power reasons, we only really saw the relationship persisting between readmission and mortality. This is true in both the cervical and lumbar groups, though we saw trends for all the aforementioned outcomes being worse in type 1 diabetes. So in conclusion, we believe type 1 diabetes confers a distinctly higher complication profile as compared to type 2 diabetes. That's after controlling for diabetic control. These risks persist in both cervical and lumbar subgroups, and as a result, we should pay special attention to the type 1 diabetics for perioperative optimization, including glycemic control, infection prophylaxis, and discharge planning. Thank you.
All right, closing out the spine section, we have Dr. Haldeman from University of California, San Diego, talking about muscle gene expression and cellular morphology in individuals with adult spinal deformity who develop proximal junctional failure.
Right on. All right. So yeah, I'm Pius. I'm one of the residents at University of California, San Diego Orthopaedic Surgery Program. And I'll be talking about some work I did in the department there, as well as with the San Diego Spine Foundation in San Diego. So I'll be talking about adult spinal deformity and the development of a complication known as proximal junctional failure following surgery. So adult spinal deformity, some citing the incidence as high as 38%, and proximal junctional failure also in some populations as high as 36%. For a long time, proximal junctional failure was thought to be a result of poor alignment, and emerging evidence demonstrates that it's more of a multifactorial development. And as of recent, we see a lot more emphasis being placed on the paraspinal muscle quality, fatty infiltration, fibrosis, and those things of those nature. And so this work is to try and elucidate any potential biological underlying mechanisms for the development of that sarcopenia. For this study, we queried a prospectively collected database of adult spinal deformity patients undergoing spinal fusion of at least 4 levels to the pelvis, and they received intraoperative muscle biopsies during the surgery. At a minimum follow-up of 2 years, we queried the database and identified 16 individuals who developed proximal junctional failure, which was defined as a pathology at the proximal junction requiring revision surgery. We age and level matched those to 18 individuals who did not develop PJF in the database. We collected some demographic variables, some preoperative sagittal alignment, and of most interest, we performed qPCR to evaluate gene expression across 40 different genes of interest, and performed histology with trichrome and lamina DAPI staining. The breakdown of demographics are shown here, with perhaps a trend towards older individuals being in the PJF group, and otherwise other variables such as female sex, BMI, levels fused, and some sagittal alignments being similar between the two groups. Of note, we did identify a differential expression in the myogenic gene ASB15, which was 2.18-fold downregulated in the PJF group, as well as an upregulation of the fatty acid binding protein FABP4 to the amount of 1.42. Interestingly, when looking at histology, we didn't necessarily see that genotype translate to a histologic phenotype. The dense collagen, fat, loose collagen, and muscle content or composition across those biopsies was no different between groups. And then on lamina DAPI staining, we also see that muscle fiber area and percent centralized nuclei were no different between those groups. So sort of an unexpected finding there, given we saw the differential gene expression. Of note, on further statistical analysis, we did note a correlation between the percent of loose collagen present in the biopsies and the gene expression of FABP4. On the x-axis here, this is the cycle threshold value for the qPCR measurement. So this is actually, the higher the cycle threshold, the lower the gene expression. So this is sort of lower loose collagen, or yeah, lower expression of FABP4 correlates with lower loose collagen content. So while previous research has relied on imaging modalities to evaluate risk in regards to PJF, when looking at muscle, paraspinal muscles and things like that, this study provides some preliminary evidence and more of a, I like to say, a proof of concept that we can start studying muscles and tissues in our human patients and don't have to rely on complicated mouse models where we try to spine mice, try to fuse mice spines and try to extrapolate from there. The studies can be done in humans, and this is evidence of that.
Thank you for those excellent presentations. We'll go ahead and open the floor for questions for the spine section.
I can ask a question for Dr. Woodard. For your paper, so you looked at x-rays at the 3-month time point, right? Do you expect there would be other differences you might see if you had longer follow-up? And the reason I ask that is, for example, in pediatric spine, we oftentimes think about coronal balance. And we know that that changes over time. What you get in your first standing x-ray or even at your 3-month follow-up may not be what you have at 6 months or even at a year or even 2 years. So what are your thoughts on that?
So we initially did this study immediately post-op x-rays, and what we saw at 3 months is that they keep increasing their lordosis. So they actually lost lordosis at the first because they were splinting post-op, which after the front back, I totally agree that that would happen. I think of the patients who do okay, they're going to continue to probably gain a little bit more lordosis. Patients who kyphose over time, depending on their alignment, I think some patients you maybe gave them too much lordosis distally, and they're going to kyphose proximally because you've overstuffed them distally. I think 3 months was just the greatest power that we had so we could do analysis. But I think that a year, patients are going to probably declare themselves if you did the right surgery or the wrong surgery in terms of your alignment targets.
Question for Dr. Chang. Thanks for a great talk. Do you have any thoughts on accuracy of measuring EBL versus looking at the drain outputs that may be potentially more accurate, how that would affect what we're seeing here?
I know one thing we had talked about was the use of TXA during surgery, especially over such a great time period, because that could definitely affect our data set. So otherwise, I think accuracy of the data, I know Cell Saver has been one thing that people have been using, and that can provide us with a little bit more accurate EBL. But I don't know if there's something that can tell us exactly this is how much we're losing, and especially when we also have to use fluids and IV. So it's hard to say for sure.
Yeah, I agree.
Dr. Haldeman, enjoyed your presentation. What's next? Is there an intervention, a training program, or something that we could optimize these muscles before surgery, knowing that if they're really poor muscles, their junctional kyphosis problem is probably more likely to be a real issue? Do you have to extend the levels proximally, or can you train them preoperatively or train them postoperatively to maybe help those muscles function better?
Yeah, that's the question. Can we get patients to participate effectively in a preoperative muscle rehabilitation program? There's studies out there of recent that show it is effective. I think whether or not the genes are really going to play a role in any of that, I don't know. Like I said, I kind of see this work as a proof of concept that if someone wanted to pursue some type of other metabolomics or secretomics or something of that nature, it can be done on human subjects, and we can learn a lot from that. The hope is that yes, patients can be prehabbed and develop, have improved paraspinal muscle quality prior to surgery. But then the unfortunate reality of posterior spine fusion is that those muscles, get dissected during the process. And so that's often a critique of this work is, sure, the pre-op paraspinal muscle quality is poor, but don't they all get torn up anyways? I don't know.
To follow up on that point, so I think you found a correlation between age as well as muscle quality, right? Did you also end up looking at, level selection matters for PJK, the type of construct you use at the upper level matters? Have you guys looked at that in addition?
The good news is that this was a fairly standardized cohort, so everyone was at least 4 levels fused to the pelvis or sacrum. I think the number of levels fused was like, average like 8 or something, so it went up to like T10 on average. And then there were no like hooks or bands or anything done at the UIV, just the UIV was pedicle screws.
All right, for Dr. Olson, do you have thoughts on why we're seeing these differences between type 1 and type 2, and then potentially how those different kind of pathophysiologies may affect A1C or the perioperative glucose monitoring more so around that perioperative period than the A1C?
Definitely. So we've actually been doing some basic science research in parallel with this, and we've looked at exactly that. What we found is that the type 2 diabetes has a distinctly altered immune and cytokine profile, and they live in a chronically inflammatory state, but then in response to an infection, they have a blunted immune response, like they're maxed out on their immunity, versus type 1 has a slightly dysregulated immunity, but a normal response. But what we do see in type 1 that might make it worse is the fragility in how dynamically the A1C and those blood glucose levels change and spike, and that can lead to microvascular complications and actually wound issues. So it's believed a lot of those problems that we're seeing in the database studies are because of wound issues post-op.
All right, great. We'll wrap up the spine section, and we will move on over to the oncology section. Thank you, guys.
So yes, we'll transition to oncology. The first paper is by Dr. Hamad, which is looking at gender and tumor size predicts recurrence in giant cell bone tumors.
All right. Thank you for the opportunity. I'm Chris Hamad. I'm a resident at UCLA. I'd like to thank the UCSF and the OREF for the opportunity to present our work, and we're going to be discussing work into discovering risk factors for recurrence in giant cell tumors. So giant cell tumors, they're a benign but a locally aggressive tumor. They occur in the metaphysis of long bones. They have a peak incidence of about the 3rd decade of life with a slight female predominance. Recurrence usually occurs in about 15 to 30% of patients, but there's really variable literature about the role of gender on recurrence, or sex on recurrence, should I say. There's a couple management options for giant cell tumor. Most commonly, intralesional curettage is used, and a number of adjuvants can be used in that setting, with bone cement being the most common, and that also is a good indicator for recurrence as well. It makes it easier to see radiographically. Denosumab is a medical treatment for giant cell tumor, but its use in the perioperative period is associated with increased risk of recurrence. And then en-bloc resection is for situations of much greater local destruction and where limb salvage is necessary. So we hypothesize that sex and social determinants of health increase the risk of recurrence in giant cell tumor. So we first had a single institution retrospective cohort. We started with 611 patients. We excluded patients for incorrect diagnosis and inadequate follow-up, and ended with 312 patients with almost equal male and female sex. Looking specifically at ADI, or the Area Deprivation Index, we had a pretty good representation throughout the 4 quartiles in the study. And moving on, so looking at individual factors of recurrence in giant cell tumor, you can see on the left side, sex is statistically significant for recurrence as an individual factor. And when you take that cohort and look individually, you can see that within the female recurrence cohort, females who had a recurrence had a smaller tumor. When further breaking down the female cohort in pre and postmenopausal patients using an age 51 cohort, you can see that all recurrences occurred within the premenopausal cohort, which we thought was interesting. And Moving on to some multivariate analysis here, sex remains significant. So you can see that there's about a 2.27 fold risk of recurrence in females, and also the bottom half of our patients who were the most disadvantaged had a 1.8 fold increased risk of recurrence as well. Looking at time to recurrence, breaking down between male and female sex, you can see that there's no difference in time to recurrence over time using this Kaplan-Meier curve. So some discussion and conclusions here. Female sex is significantly associated with recurrence in our cohort. Tumor size, adjunct use, and location were not. The most disadvantaged patients in our study had a higher risk of recurrence, and this really highlights the need for interventions improving access, surveillance, and follow-up in this patient cohort. And future studies are really needed to look into some of the hormone and biological reasons of increased recurrence in patients of the female sex. Thank you to my team and lab who made this work possible, and shout out to Audrey who did a lot of the patient chart review for this study. Thank you so much for your time and attention.
Thank you. We'll move on to Dr. Sridharan, who's going to present on predictive factors of having a secondary UBC-related pathologic fracture.
Good morning, everyone. My name is Mathangi. I'm one of the PGY3s at UCLA. As mentioned, I'm going to present on repeat pathologic fracture after conservative treatment of unicameral bone cysts. So moving on to some background information, as we all know, there's limited consensus on when we should intervene for UBCs. Oftentimes, especially in the upper extremity, pathologic fractures are treated with conservative management. And as we see here are the classic pictures of a benign fluid-filled unicameral bone cyst, one in the upper extremity with that classic fallen leaf sign, often treated with conservative management, versus the lower extremity, especially in the proximal femur, where we're less likely to pursue conservative management because a pathologic fracture can be devastating. But overall, in the literature, there are inconsistent rates of spontaneous healing in these pathologic fractures in UBC, honestly with and without surgery, and I think it's complicated by the fact that these are just very rare presentations, and it's hard for a single institution to comment on this. So I'd like to say that I asked this question after a very rigorous literature search, but it was actually because I missed an OID question and I took the reasoning for conservative management very personally. So we wanted to take a look at who might have like a repeat pathologic fracture associated with these. Secondarily, because we had the cohort, we decided let's also look at factors requiring surgical fixation for any reason whatsoever. So at our institution, we are fortunate to see a lot of these, and we were able to look at a consecutive series of patients between 2012 to 2025, looked at several demographic variables, notably insurance status, pain level, where that cyst is, and presence of a pathologic fracture at presentation. We also did a brief radiographic review looking at skeletal maturity, location within the bone, the size of the cyst relative to the bone width, cortical involvement, and active status, which is historically defined as a cyst being within 1 centimeter of the nearest physis, as demonstrated here. Just to make sure that we were adequately capturing these patients properly, we wanted to make sure they followed up with an orthopedic oncologist for at least 6 months after presentation. And again, here were our primary and secondary outcomes. We were able to look at a cohort of 179 patients that were predominantly pediatric, which is consistent with what we see with the natural history of these. Most patients had minimal to moderate pain, most commonly in the proximal humerus. Most cysts had cortical involvement, and most cysts were pretty large compared to the rest of the bone width. Again, we've seen this in the natural history of UBCs. So moving on, almost 70% of patients presented with a pathologic fracture, the vast majority, were treated conservatively. And I think most strikingly, nearly a quarter of these patients that were treated conservatively after a pathologic fracture sustained a repeat pathologic fracture. Of those 27 patients, they were a lot younger than the rest of the cohort. Most of them were male, and most of these cysts were in the upper limb, which is kind of a chicken and egg situation because we're probably going to fix them in the lower limb before there's a fracture. So again, this is just demonstrating, just strikingly, these 4 factors really kind of hit home from this cohort that these were the types of patients that were more likely to have a repeat pathologic fracture. Of note, our institution is set up such that regardless of insurance status, you will get your foot in the door, especially for the pediatric patients. So this was an interesting finding for the public insurance that we're trying to look at with some more controlled studies going forward. Briefly, 50% of the patients underwent surgical fixation for any reason in the cohort. Interestingly, private insurance was a predictive factor for that, as well as having moderate to severe pain and a UBC in the femur. Again, as I said, that was probably going to happen anyways. We don't typically treat those conservatively. So overall, I really like this study for us because for me personally, it taught me that there might be a clinical profile that we would counsel the child and their parents and guardians differently. Like if they have a younger age, they're a male, and the cyst is very close to the physis, they might be more likely to have a repeat pathologic fracture. And for those patients, we might consider just fixing it after the first one to prevent repeat injury, more pain and immobilization for these patients. That's all I had. Thank you.
All right, thank you for that talk. Dr. Newman-Hung is up next, and she's going to be talking about characteristics and recurrence risk of upper extremity soft tissue sarcoma.
Morning, everyone. I'm Nicole Newman-Hung. I'm a PGY4 at UCLA, and I'm excited to continue the UCLA ONC train here and talk about characteristics and recurrence risk in upper extremity soft tissue sarcoma. Soft tissue sarcomas are rare and heterogeneous tumors comprising of over 50 histologic subtypes. And these tumors can have devastating effects on patients with high rates of local recurrence and metastatic disease development. Surgical resection and radiation are mainstays of treatment for these patients. And risk factors for local recurrence for lower extremity and truncal tumors have previously been described. However, given upper extremity tumors may have unique presenting features and pose specific complex surgical challenges, these tumors in particular warrant further investigation. As such, we had two primary aims of this study. First, to describe presenting patient and tumor characteristics in upper extremity soft tissue sarcoma subtypes. And second, to investigate patient, tumor, and treatment-related factors that may contribute to 3- and 5-year recurrence risk in these tumors. We conducted a retrospective review of our institutional upper extremity soft tissue sarcoma surveillance database, comprised of patients with primary soft tissue sarcoma of the upper extremity who underwent surgical treatment from 2012 to 2022. We then recorded patient demographics, tumor and treatment-related details, and oncologic outcomes. Finally, we performed univariate and multivariable competing risk analyses. Overall, 190 patients were included. The median age at presentation was 52 years old, and the majority of our cohort was male and presented with grade 3 or high-grade tumors. Median tumor size was just over 7.5 centimeters in greatest dimension, and you can see there's great heterogeneity in the histologic subtypes out of these 190 patients. The overall recurrence rate was 24%, and the mean clinical follow-up was 4.9 years for these patients. Presenting our results for tumor characteristics, we looked at the influence of tumor histology on presenting tumor size, using epithelioid sarcoma as the reference group in this linear regression, given its known small size on average at presentation. And we found that those subtypes that are bolded in red there, myxofibrosarcoma, UPS, undifferentiated sarcoma, and liposarcoma were all significantly larger tumors than those who presented with epithelioid at time of presentation. When we looked at the influence of tumor histology on patient age at time of presentation, using synovial sarcoma as the reference group, again, given this is well described in the literature as a subtype with younger patients at time of presentation, we found significant differences in leiomyosarcoma, undifferentiated sarcoma, liposarcoma, UPS, and myxofibrosarcoma compared to those with synovial at time of presentation. Moving on to our recurrence risk analysis. On univariate analysis, these were the factors that were significant in terms of increased risk of recurrence, female sex, undergoing initial excision at an outside hospital, myxofibrosarcoma histology, undergoing positive or close margin surgery, and undergoing adjuvant radiotherapy. When we did a fine and grade competing risks model, which takes into account the competing risk of death versus experienced recurrence, these were the factors that held up in terms of significance. So female sex, increasing age, undergoing initial excision at an outside hospital, and undergoing positive or close margin surgery. And this is the 5-year result, which is strikingly similar. So in conclusion, we've shown that descriptively, upper extremity soft tissue sarcoma does present with different tumor characteristics in terms of histology and patient age. We found that modifiable risk factors for experiencing recurrence may include undergoing index surgery elsewhere, not at a sarcoma center, and undergoing positive and close margin surgery. And I think the biggest clinical takeaway here is that specifically with upper extremity lumps and bumps, we encounter them frequently, and we have this bias to think that it's probably a ganglion, or maybe it's a lipoma, because they're oftentimes painless and small at time of presentation. But surgeons should have a low threshold for referral for a full sarcoma center workup if there are any concerning symptoms. Thank you so much.
Thank you. Last paper in this section is by Dr. Gettleman, and he'll be talking about income impacts overall, but not cause-specific survival in patients with chondrosarcoma.
Thank you to the OREF and UCSF for hosting this. My name is Dr. Gettleman. I'm a PGY2 at UCLA. I'm going to spare you the repeat of the mouthful title, but we're talking about chondrosarcoma and socioeconomic status. So chondrosarcomas account for 20% of all primary malignant tumors of the bone, and many previous studies evaluating socioeconomic status in bone malignancies such as chondrosarcoma focused more on the Cox proportional hazard model as opposed to the fine gray model. And the issue with that is that there's some overestimation of risk when using the Cox proportional hazard model. So the primary aim for our study was to assess the prognostic value of socioeconomic status operationalized as income and morality in chondrosarcoma using the fine gray model. The secondary aim was to identify additional mortality risk factors including age, sex, race, primary tumor site, and histological subtype. So we performed a retrospective cohort study using the SEER database of patients diagnosed with chondrosarcoma. We looked at socioeconomic variables where we basically grouped the patients into 3 income groups. The low income was less than 55,000, middle was 55 to 70, and high was greater than 70. And we used county-based population data to delineate rural versus urban residency with a number of less than or greater than 250,000. And the covariates, as I alluded to, age, sex, race, tumor, histology, and primary tumor site. So for our statistical methods, again, we used Cox proportional hazard for our cause-specific hazard, and we used fine gray to assess for competing risks. So in our study, we had a total of roughly 3,700 patients that met the inclusion criteria with a mean age of 53. Of those patients, 73% were high income, 18 were middle income, and 9 were low income. There was a significant difference, as you can see delineated by the asterisks, in sex by income group, with a larger proportion of high income households being male and a larger proportion of low income households being female. My apologies. Statistical significance was also seen between the income groups, with rural areas having more low-income patients at 58% and high income being 3.4%. So continuing with our data, in the Cox model, low income was linked to a significantly higher risk of mortality with a hazard ratio of 1.43, but when accounting for competing risks using the fine gray model, the effect size was attenuated and the confidence interval widened, going from 0.95 to 1.94, suggesting that the Cox model may overestimate the impact of socioeconomic status when competing events are not considered. Continuing on, using the cumulative incidence curves showing higher mortality in low-income patients, about 5% greater at both 5 and 10 years compared with high-income groups. However, this difference did not reach statistical significance in the fine gray model with a p-value of 0.089. So consistent with the Cox model, now we're looking at types of tumors. The mesenchymal and dedifferentiated chondrosarcoma carried significant higher mortality compared with the not otherwise specified chondrosarcoma, with subhazard ratios of 2.5 and 3.1 and a p-value of less than 0.001. Tumors of the pelvis, down on the chart on the bottom right, were also associated with nearly double the risk of mortality compared with axial sites, subhazard ratio of 1.9. And again, these are kind of expected findings. So as we go back to our aims, so using the Cox model, both income and rurality appear to be significant prognostic factors for mortality. However, these effects attenuated and lost significance with the fine-grained model, although lower income did trend towards higher risk, and while rural patients surprisingly had a lower risk than urban patients, despite the higher poverty rates. And then our secondary aim across both models, as I alluded to, the mesenchymal and dedifferentiated subtypes carried the highest mortality risk compared with NOS, consistent with prior research showing the poorer survival and higher metastatic potential with these subtypes. So just to kind of close it up, nationwide cancer registries such as SEER and NCDB are powerful means for investigating these rare tumors and have increased in popularity over the past decade. But I think it's important to think about the statistical analysis we're doing and taking the picture as a whole to provide more balanced estimates and accurate representations of what's causing these outcomes in patients and being able to have those conversations with families when we're counseling them when these diagnoses are made.
Great, thank you for all those talks. These papers are now open for discussion.
I'll ask a question first. Dr. Newman-Hung, I liked your talk. Nice to see you. I'm about an hour away from doing a ray resection for a sarcoma patient. She's a female. And maybe you mentioned this, I didn't quite hear it, but why is the risk so much higher in women than men for sarcoma?
We were just talking about this because across our kind of onc study group, we've found across whether it's soft tissue sarcoma, giant cell tumor, which is benign but aggressive, that seems to be a trend, and in the onc literature in general. And I think beyond kind of the hand-waving answer of, more disadvantaged groups, whether it's racially, ethnically, socioeconomically, and women when it comes to sex, do worse, we're trying to dig out why. I think in the ortho-onc literature in particular, there's a delay in terms of diagnosis and presentation. Women typically, this is generalization, but women, I think it was the SERV-SARC study showed that there was a greater than 3-month delay in soft tissue sarcoma compared to their male counterparts, just from onset of symptoms to diagnosis and treatment at our sarcoma center. So I think that's a huge part of it. I think when we're talking about upper extremity in particular, the background side, I didn't dive deeply into it, but the reason why it poses a more complex surgical issue is just because you're not working with much to get negative margins. So then it leads to what could have been possibly just a wide resection now becoming a ray resection or an amputation because of a delay in not being able to achieve a negative margin resection without doing a ray resection, or in someone presenting to maybe perhaps a community center, non-sarcoma center, doing an unplanned excision thinking it's a lipoma, and actually they've spread microscopic tumor bed everywhere, and now they're left with having to get a ray resection.
All right, this is a question, I think, for all of you guys. These are great studies with a lot of data. Is this enough data to change your management and counseling of patients based on the variables that you guys have found? And then how does it change for factors that are modifiable versus non-modifiable? How do you talk to a patient about sex or gender and or income status when those things may or may not be changeable?
I'm holding the mic, so I guess I'll start. I think for the first part of your question, I think we are very fortunate to be at an institution that does see a lot of these referral patients, and because of that, we do have a unique perspective on being able to ask these questions and have a institutional database that would change clinical management. Like for me, for UBCs, I mean, I didn't know much going into it, and even our single institution was a higher cohort than what I've seen in the literature. So when we ask the right question and if we have the right patient amounts relative to things that are very underreported and understudied just because of what they are in oncology, then yes, I think all of these studies would change my practice and how I talk to patients. Modifiable risk factors?
Sure. I'll quickly say in regards to my study, there's really variable literature even on sex on recurrence. So some studies will say that male sex is actually linked to higher recurrence, but we saw something completely different within our cohort. So I would probably just counsel our patient, hey, that there is a multitude of data out there. We have one of the largest retrospective cohorts, and this is what we found, but we don't know for certain. I think with the modifiable risk factors, quoting our literature in the same way and saying, hey, we know that you have a harder access to get in, you may be lost to follow-up, and we'd like to take closer attention to you, especially if we identify a patient being at higher risk of or being more socioeconomically disadvantaged and higher risk for recurrence or loss to follow-up. So.
And quickly, just in regards to my paper, I think it's figuring out a way to complete the ecosystem for these patients and provide them resources. That's kind of a way to change practice. You know, I'm working with Dr. Bernthal on trying to create a national physical therapy platform for these patients who undergo endoprosthesis type procedures that live in these communities that have physical therapists that have they don't know what they're doing because they haven't seen it. And so we're giving them sort of a user-friendly platform that they can rely on, and hopefully that's something that affects these patients who are maybe further away from being able to access, higher levels of care.
First of all, congratulations to the four of you and to Dr. Bernthal and the team at UCLA Oncology. Amazing talks. I'm a pediatric orthopedic surgeon, so I'm going for the pediatric talk here. Thank you for actually publishing on UBCs. There's not a lot of literature to help us guide treatment in these patients. So one of your findings was that boys who are young have a higher rate of refracture. So that is consistent with the population in general that suffers upper extremity injuries, right? So young males are more likely to break their arms than females or older males and females, so that's not surprising. So I'm wondering if you looked at mechanism of injury of those recurrent fractures to see if there was something atypical about them or if they were just fall from height like children always do and break their arm, and because that's a place of weakness in their arm, they broke their proximal humerus instead of their supracondylar humerus. So that's my first question. And then my second question is, for those recurrences, I might have missed it, but did you look at then did they subsequently go on to heal? Because a common adage in pediatric orthopedics, particularly for UBCs in the proximal humerus, is it might break once. That's how you actually know it's there, right? And so then you treat it with a sling and you let it heal. And then if they break again, it usually goes away. So one of the things that you could really add in this study, if you haven't looked at it already, for those of us who are going to use this to guide management, is did they go on to heal subsequently after that second fracture? So I'm wondering if you have that data.
100%. Thank you so much. That was, before we started the study, that was kind of the pathway that, the oncology attendings kind of told me about when I wanted to look into this. In our cohort, not many healed. I think out of the 27, 2 went on to heal, and 1 that was only after surgery for that patient. I thought I would see a higher rate of healing. I know the common adage is now after the second time, it just changes the biology, and I do think there is there is truth to that, and that's why there is a proportion of them that heal. But when we look at some larger cohorts that are coming out, I'm sure you've seen them, there are some that are now topping off over 100, or there was one in BMC with 80 patients. The healing rate is still around 50%. So we're still looking at 1 in 2, which again, for a parent, I mean, I don't have children yet, but for a parent that might make a difference of if it's only a 50% rate, we might as well fix it now, was kind of our thinking with this. As far as young men, young boys, breaking again, I agree that there might be a little bit of confounding, a little bit of natural history. Most of these were low energy in patients with minimal pain with cysts in the humerus. So I do think it is hard to pull out from that history whether they were just goofing around. But I think that's kind of part and parcel for that patient population, and especially if they don't have a way to guard, because they might know it's there, but a 5-year-old's not going to remember that they don't have something that's like very painful, it's in their arm, they're not feeling it all the time. We can't really protect their behavior, which again might drive clinical decision making for that parent saying, okay, I'd rather that we just go in and curettage and graft it now with maybe a steroid injection, because I don't want my child to fall off the monkey bars, and then we go through this process again with a co-opt or a sling. So we'll see. I mean, I think we probably need a larger cohort. We probably need some more prospective studies that incorporate that shared patient decision-making with the parent to see if we're going to change anything by suggesting this to them.
Dr. Schroeder, sorry to pick on you, but I'm also a pediatric orthopedic surgeon, so I can't resist. So a couple of questions. One is proximity to the physis. Why do you think proximity to the physis matters? And what was that, centimeter? Is that what you define it as? And, that. And the second question is, have you had a chance to build a model with the risk factors you identified? Because the contribution of these factors is probably different in terms of risk, age, sex, all of those. And so have you done that? And if not, I would suggest that you do it because it would be helpful.
Yeah, 100%. I want to build a model. But going back to your question earlier too, like there are 180 patients, which is great for oncology literature, but there are also only 180 patients. So anytime we tried, we were just still so underpowered. There are efforts underway, and I'm happy to talk to you about it after too, because it does involve other UCSF attendings as well, to maybe build a larger cohort and see if we can just, whether it's a predictive model or just something a little bit stronger of guidelines that might suggest management and more concrete than just younger age male and close to the physis. Speaking of that, close to the physis, there is some oncology literature that's looked at this, not in UBCs, but just other cystic lesions. I saw it a little bit more in aneurysmal bone cysts. I think, again, it's just a way of quantifying more than there is a cyst close to the physis or far to the physis, that there was a guideline of a centimeter. So we decided to adopt that objectively. I think if we did this going forward in like a prospective study or a bigger study, we should probably incorporate radiologists to maybe come up with more distinct criteria than just something that's a guideline in literature. My interpretation of that is just one weak spot closer to another weak spot in the physis, and when you have these kids jumping off monkey bars and not knowing that there's a cyst there, it's just more prone to breaking, and there's a lot of growth happening there that's probably affecting the biology differently than if it were like 6 centimeters away. I do think that's probably confounded by age a bit, because in our data, there was a big variance in like the average distance from the cyst, which I think is confounded by age. So need some further studies to suss that out a little bit more. Yeah.
As the child is aging, growing, and it's moving away from the growth plate, it's theoretically, it's like burning itself out of it.
Yeah.
To get greater vertical integrity as it gets. So those are other things to look at.
Perfect.
Definitely talk to your pediatric orthopedic colleagues who have different ways of thinking about this too, in addition to the oncologist.
Wonderful. Thank you.
And one last question for Dr. Newman-Hung. Whenever we talk about treatment in the community and referring to a tertiary center like UCLA, UCSF, any other large center, in your study in particular, are there clearly a lot of these patients can't travel that far for care. So are there some factors that you think are somewhat helpful for those taking care of this in the community, that they could provide local care for them and not necessarily transfer them or provide, have them drive to Los Angeles or to San Francisco, ones that maybe have a lower risk of recurrence? Which ones would you identify as being okay to have local care?
I think part of the issue was a lot of the folks who had an unplanned excision, for example, at a non-sarcoma center. And we did not quantify like distance. We have all the ADI related information, but we didn't correlate that with like rurality, distance traveled to our center. But a lot of them didn't even have cross-sectional imaging. So I think just starting with like the correct pre-op, but not even talking about surveillance, just preoperatively make sure that if you have any like suspicion that this doesn't smell right or doesn't smell like a ganglion or typical ganglion, just get cross-sectional imaging of some sort to start. So I think it could start as simple as that and just kind of educating people on that. And then, yeah, the surveillance problem, and I know all 4 of our studies are somewhat related to that, I think is a different beast. But I think preoperatively, get cross-sectional imaging. Sorry, this concludes your thesis defense.
A quick question about sort of the outside hospital concern with tumors and recurrence. With all the telehealth opportunities we have now, is there a way to really leverage that technology such that we could provide a readily available consulting service for here's what you need to do next, and perhaps even guide their biopsy so that it doesn't create a bigger problem down the road?
I think for the surveillance piece, integrating telehealth is, now I'm getting to the second part of Dr. Sarver's question, but that is where telehealth could be leveraged more. I think like an initial consult at a sarcoma center is still wise. Because just being able to examine, like seeing a patient in person and examining them cannot be replaced over Zoom, I think. And I think when you're at a sarcoma center where we have weekly tumor board discussions where Dr. Bernthal, Dr. Wessel, Dr. Chris can just call our rad-onc team from clinic right there and then there and make sure, be like, hey, let me get this patient on your radar now. That can't be replaced. Like that in-person encounter would take 5 telehealth encounters to be bounced back and forth to be like, did you get the referral here? Did you follow up with this person? So I think starting with an in-person encounter and then coordinating neoadjuvant therapy if they need it, their biopsy before that, and their surgery. But I think for surveillance, that's when we can leverage telehealth more.
Well, it sounds like lots of room for improvement. So with that, we will wrap up this session and we'll take a little break.
We're going to start our next session here. If everybody could please have a seat. Thank you. All right, before we start, quick housekeeping. If the residents are rating and scoring the other presenters, if you guys could give those forms to Deborah. Deborah is just out front. Apparently you cannot win an award if you do not submit, and you also cannot vote for yourself. So just FYI, but get those forms over to Deborah if you can. We will go ahead and start with our last session. This is a little bit of a grab bag. This is gonna be hand, pediatrics, trauma, and a little bit of health policy. We'll start with Chris Chang from Stanford University. He'll be our hand fellow next year, so you may see him around. Exactly. He'll be talking about, does retrograde insertion of a threaded intramedullary nail for metacarpal fracture fixation weaken the biomechanical properties of the extensor mechanism?
All right, thanks everyone. I'm Chris Chang. I'm a PGY5 at Stanford. Thank you to UCSF and OREF for hosting and allowing us to present our work today. I'll be giving our talk titled Retrograde, or Assessing the Biomechanical Properties of the Extensor Mechanism After Retrograde Nailing. Thank you to my other co-authors. The senior author does have a disclosure with Acumed to provide. Acumed did provide cadavers and instrumentation for our study. Metacarpal fractures, we know, are one of the most common musculoskeletal injuries. And for those that are indicated for surgery, we know that there are various options for surgical fixation. And retrograde intramedullary nailing has become one of the most popular or increasing in popularity owing to the biomechanical strength of fixation and the minimal soft tissue dissection needed for implant insertion. But we do know that with retrograde insertion, it does risk injuring the extensor mechanism. And several studies have looked at the injury rate of the tendon. And we know that it can, percutaneous insertion of a retrograde nail can injure the extensor tendon up to 70% of the time. And some other studies have looked at kind of the footprint of injury left after retrograde nailing, but they only note the injury involves typically less than 50% of the tendon width. And despite this, we've anecdotally found that some surgeons are still kind of unsure how best to manage the extensor tendon during retrograde nailing. And so we kind of designed this study to try to address some of the questions around that. And so first we wanted to look at, does the footprint of injury to the extensor mechanism biomechanically weaken this? Does that implant insertion site become a tensile mechanical failure point? And then are mini-open tendon-sparing approaches potentially more protective of extensor biomechanical properties? So we designed this cadaveric study. We had 8 paired hands and we excluded the thumbs, so a total of 64 fingers and their extensor mechanisms. And we did randomize fingers from the same hand into separate testing groups. So we had 1 control group without any instrumentation and 3 testing groups as delineated in the image on the right. The percutaneous transtendinous group kind of simulated going through skin and soft tissue without any preparation, and with the guide wire placed directly through the extensor tendon, over drilling, and then implant insertion through that defect that was created. We then had a longitudinal split repair group. First we created a 5mm longitudinal stab incision through the extensor tendon, and then placed the guide wire and instrumentation thereafter. And then the transsagittal band group was created by retracting the extensor mechanism so that we place the guide wire through the ulnar sagittal bands and then instrumentation to follow thereafter. Once all the instrumentation had been passed, the extensors were harvested and then loaded for tensile testing. They were placed and loaded at a rate of a millimeter per minute. And then from the load displacement curve, we were able to assess the load to failure and the stiffness. And then at the end of the testing, we were able to assess the failure scenario based on how the tendon had failed during tensile testing. We did a sample size study to our power analysis that did give us a power of 30% difference between load to failure between test groups with 60 specimens, so we were over that. And so this is kind of the meat of our results, both in tabular and graphic form. And so this is the load to failure and stiffness based on testing group. And what you'll see is that there's no significant difference between the testing groups and control for load to failure or stiffness. And I think the absolute, the magnitude of the load to failure is important here, and that for every group it did average well over 300 newtons. And this is important to contextualize based on analytical models that suggest physiologic loads in the extensor tendon really don't exceed more than 200 newtons. We did also stratify based on which metacarpal the extensors were harvested from, and we did find that load to failure for extensors from the 2nd and 3rd metacarpal were greater than those harvested from the 5th metacarpal, but stiffness remained the same. And then looking at the failure scenario, we did divide categorically the failure scenario based on how the tendon failed. And so drill site rupture described those that failed at the instrumentation site. Distal bone avulsion was if the tendon failed kind of distal to that, and then proximal as well. And you can see, so based on Fisher exact tests, that the overall cohort does have a significant difference in distribution. And we did note that the percutaneous transtendinous group failed 44% of the time, so 7 out of the 16 fingers failed there, as opposed to the other groups. Now, unfortunately, because of the sample size, we're underpowered to assess pairwise assessments, and so it's hard to know whether the statistical difference is comparing PTT versus the control, or PTT versus any of the other mini-open tendon sparing approaches. And so based on our results, we concluded that retrograde intramedullary implant placement through any of the approaches does not significantly decrease extensor load to failure or stiffness compared to your controls. And then we did note that the implant insertion site does potentiate a failure point, but again, in the context of the load to failure occurring at much higher than physiologic loads, we do feel that any approach, percutaneous or mini-open, likely has minimal clinical impact on extensor mechanism integrity during early functional motion. So that's all I have. Thanks.
Thank you. Next up will be Dr. Kadim talking about guided growth treatment for lower extremity coronal angular deformity correction. We will keep moving on. We have Dr. Dong talking about osteochondral autograft from the proximal tibiofibular joint for reconstruction of acute tibioplateau fractures with severe chondral defects.
Good morning, everyone. I'm Oliver, one of the residents from the St. Mary's program, and I'm excited to talk about a technique project we've been working on using osteochondral autografts from the proximal tib-fib joint for reconstruction of acute tibioplateau fractures. And neither I or any of my co-authors have anything to report related to this study. So in brief, general principles for treating plateau fractures include restoring a neutral mechanical axis by recreating anatomic alignment, and additionally by restoring the condylar width and repairing the menisci when indicated, re-enables efficient load transfer from the femur to the tibia. And importantly, we also need to recreate a stable knee, and paramount to this is anatomic reduction of the articular surface. But what happens when you have a case like this, or have to reconstruct the tibial plateau with pieces like these? So the question arises, what options are there when you have severe comminutions, small free articular fragments, or delaminated cartilage fragments? Proceeding to a total knee, sure, if they're elderly with osteoporotic bone, but in younger candidates, it definitely would not be an ideal option. Osteochondral allografts can sometimes be considered, but it may be hard pressed to obtain them in the acute setting. But what about autografts? So recently, iliac crest grafts have been shown to be used to help reconstruct the joint surface, but iliac crest harvesting has its own complications, such as persistent pain and infection risks. And additionally, iliac crest grafts do not have articular cartilage. So could there be an option for autografts that include articular cartilage without significant morbidity at the donor site? That's where the proximal tib-fib joint comes in. So the joint can be fairly easily accessed through a standard anterolateral approach to the lateral tibial plateau. The articular cartilage from both the tibia side and the fibula side can be harvested, yielding up to approximately 1.5 by 1.5 centimeter pieces that can then be molded and manipulated to reconstruct the articular surface. However, care needs to be taken to preserve the fibular attachment of the LCL, and also need to consider the common peroneal nerve, which is within proximity, but should be relatively safe unless we skive to posteriorly or inferiorly when harvesting these articular facets. So the first case is the most recent one we did. Is a 54-year-old female who fell off a bike, sustaining this left Schatzker 2 tibial plateau fracture. Here are the initial radiographs, some CT slices. So as you can see that, there's significant articular comminution and depression, also extension of the fracture into the proximal tibia diaphysis. So for her, she was discharged after 1 day and then returned 4-day surgery for acute surgical fixation. So there's this short video here. So on exam, there was actually quite a bit of instability on valgus stress. We utilized the anterolateral approach, as you can see here. We did a submeniscal arthrotomy. The femoral distractor was placed. And what we noticed was the articular rim was actually fairly well preserved, but there was extensive articular depression, as you can see here. And many of the articular fragments actually quite comminuted as expected, and we were really only able to use 2 pieces to begin building our articular block. So to augment our articular block and to create an actual articular surface, we decided to harvest the articular facets from the proximal tib-fib joints. This was done by using osteotomies through the fibula head using an osteotome, making sure to preserve the LCL. And then these 2 pieces were then molded and attached to the articular block that we were beginning to make. And calcium phosphate bone putty was then added around it to provide additional stability. So as you saw briefly in the video, here are what the pieces look like intra-op. On the left are the native articular fragments. As you can see, they're quite unreconstructable, and there's also fragments of delaminated cartilage. And on the right are the harvested tibio and fibular articular facets of the proximal tib-fib joint. Here are some intra-op fluorofilms. And on the left, you can see the reconstructed articular surface. And on the right, you can see the defect filled with crushed cancellous allograft after near the end of the case. Here are the final fluoroscopic images and after placing a 10-hole lateral proximal tibial plate. Postoperatively, she was made non-weight bearing to her left lower extremity for 6 weeks, but we allowed her to start working on range of motion immediately afterwards. She was seen at 2 weeks and 6 weeks post-op with stable x-rays. At 6 weeks, her knee range of motion was around 0 to 95, and she was advanced to weight bearing as tolerated. X-rays remained stable at her 3-month post-op appointment with near functional range of motion, and she has had no issue being fully weight bearing on her left leg by this point. And she was most recently seen at her 6-month post-op visit with essentially full range of motion of her knee, and she had no varus or valgus instability on exam, and x-rays show good interval healing. So second case is a 39-year-old gentleman that we did who drove his car off a cliff, sustaining a left Schatzker 6 tibial plateau fracture. Here are the initial injury films, some CT slices. So pretty obvious, there would be severe comminution, impaction, delamination. These are all things that will make reconstructing the articular surface quite challenging. So same thing for this case. The articular facets are harvested from the proximal tib-fib joint and used to construct a portion of the lateral articular surface. Here's some intrafloral films and final floral films here. So post-operatively, he unfortunately developed a flexion contracture at the knee. At his 3 months post-op visit, his x-rays looked good, but his range of motion was only around 12 to 100 degrees. So he underwent an open posterior capsule release, and we also did a diagnostic scope with him at the time, which actually showed good healing of the medial and lateral plateaus here. And then he was casted in full extension for 6 weeks, and by 3 months post-op from the contracture release, the patient was actually having good motion and was pretty much walking normally. This is it. This is a video of his gait at that time. And then at 12 months after his initial surgery, he was ambulating pain-free in his left knee. And radiograph shows stable construct and a bony union of the fracture. So in summary, to our knowledge, this is a novel technique, and there are no prior case reports of the use of autograft from the proximal tib-fib joint for reconstruction of tibial plateau fractures. And this technique serves as a unique option for younger patients with severe cartilage damage who do not have underlying arthritis and who would not be a otherwise good candidate for an acute total knee. And the harvest can be done with minimal morbidity to the patient, as we have seen in clinic follow-ups, at least in the short term. And that's all I have for you. Thank you, guys.
All right, last for this section is going to be Dr. Martin, talking about the effect of body mass on reoperation rate for distal femur fractures.
Thanks for hanging on, everyone. I think I'm the last person today, so you're very close to lunch. I'm Anna. I'm one of the 4th years at St. Mary's. So we're going to talk about the effect of body mass on reoperation rate of distal femur fractures today. And note here, we're talking about body mass as an entity, not BMI specifically. So these are my co-authors who also have no conflicts of interest, but thank you so much for helping us with this study. So a brief background, so the incidence of non-union of distal femur fractures is approximately 10 to 22% reported in the literature. Known risk factors include age, high BMI, so again, body mass index, not body mass, smoking, fracture comminution, and infection. And there have been relative advances in surgical technology and the way we're doing the surgery, but the rates of non-union have not significantly decreased. Obesity is also a known risk factor for reoperation rate for non-union distal femur fractures, and the theory of our study is that increased load placed on the fixation constructs may contribute to non-union, and we're talking about load in the kind of biomechanical sense, not BMI of the patient. So the abstract actually that you have in your booklet is been updated. We doubled the patients that we included in the study since we wrote it to try and achieve statistical significance. So this was a retrospective review. It's performed using the Kaiser database. And we screened 725 distal femur fracture patients. These were all treated by fellowship-trained orthopedic trauma surgeons, trying to account for a least amount of variability in technique and training when treating these. We have 73 in our high body mass cohort, and the weight ranges from 111 to 189 kilos. Our cutoff was 110. And then we have a matched 73 patient cohort with a body mass which was considered standard, so 66 to 74. So the primary outcome of our study was reoperation to promote union. This was terminology partially determined by when we submitted it. They wanted us to call this reoperation to promote union rather than non-union, but that is what we're trying to assess here, is non-union. The secondary outcome was the use of dual fixation. The way we did this was we looked at the operative reports for the patients from their initial index surgery and then any subsequent index surgeries. The definition of single fixation was either a lateral plate, a medial plate, or an intramedullary rod. Dual fixation was the use of a medial and lateral column fixation or a hybrid nail plate fixation, which, as you all know, is very popular right now in the literature. So the results, we did have a pretty high proportion of patients who had a high mass, so over 110. 10% of the cohort we examined had a mass of over 110 kilos, which, as you can examine, could be putting a lot of strain on the constructs if you're using a single method of fixation. In terms of reoperation rate, there was a pretty big difference in those between the standard mass body group and those in the high mass body group. So 5.5% in the standard mass body group had a reoperation to promote union, and 20% had this in the high body mass group, so pretty significant difference. And in terms of dual fixation, again, very low in the standard mass body group, only 5% of our patients had it, and almost 20% in the high body mass group. And since we expanded our cohort, these numbers achieved significance. So the p-value was 0.02 between reoperation rate and dual fixation, comparing the body mass, the average, and the high body mass groups. So how does this fit into the literature? There has, as we talked about earlier, been significant literature talking about the factors that contribute to non-unions in these distal femur fractures. Most of the time they're talking about body mass index, but as you can imagine, there are patients who could have a normal BMI and be in a high mass group, or the reverse. There were a fairly substantial number of patients who had a high BMI but were still under 70 kilos. So it's something to consider. It's not just the composition of the patient, but the actual biomechanical strain that they're going to be putting through your fixation. This, again, is not the first time this has been looked at. This has been looked at in biomechanical models. This was a kind of finite element analysis, which showed that doubling the axial load from a 70 kilo control group to 140 kilo high body mass group increased the interfragmentary strain on average 76%, so very substantial. So what does this actually mean? I think our literature, or what we've showed here, is that the orthopedic trauma surgeons have a decision-making heuristic here that is reflected in our data, and that patients who have a higher mass may require additional fixation to provide an appropriately stable construct. And it also reinforces that patients who have a higher mass are undergoing surgeries to promote union subsequently. So it's something which surgeons are already doing, and if they're not, that's something we should consider in our decision making for surgery. Also, perhaps something in our development of implants as well. If patients are considered standard at 70 kilos, we can show here with this data that not everybody is a 70 kilo patient, and something to consider in our nails and our plates when we're developing them. And that's it.
Excellent, thank you. We'll open up the floor for questions. I'm happy to start. I'll take the easy one, Chris. Looking at your biomechanical models, there was no fracture that was created and you had taken the skin off, so it's pretty easy to see where your start site was.
Right.
When you're doing these in the OR, oftentimes you have a short distal segment. The resident is the one kind of putting the K-wire in, maybe through an 18 gauge needle. How do you think multiple either stabs with the guide wire and or a K-wire, a needle would change the biomechanical properties of that tendon?
Yeah, certainly. I think that's also one of the sort of thoughts that we had. We kind of had one good shot at it, whereas, intraoperatively that may not always be the case. So certainly a limitation of the model. But I think that just speaks to kind of doing what you're most comfortable with doing. So if you feel that you're safest opening and looking at the tendon and protecting it, and you feel like you feel safe doing that with multiple passes with your guide wire, then that's appropriate too. I don't think there's a wrong answer in doing that.
Yeah. Would any of those things change your post-op protocol or what you allow the patient to do afterwards?
I don't think so. I think that the data pretty well shows that the load to failure is really beyond physiological loads. And I think the numbers I quoted were like 200, and that's looking at elite level climbers and their maximum grip strength. And there aren't really other sort of maximal extensor like forces in the finger that you're going to experience beyond that. So I think early postoperative motion is fine. I think if you're happy with your fixation, I think that would be the most, that would be the thing that would limit you.
Awesome, thanks.
It's a question for Oliver. Very innovative kind of technique over there. So I wonder, first question is, anybody reported this before in terms of using a tib-fib joint to reconstruct the tibial plateau? And the other thing too is that what happened to the tib-fib joint afterwards? Do they have extra movement, and is that something concerning? And also, the contour of the lateral tibial plateau a little bit unique. That is very convex. So the joint of tib is relatively flat. Yeah, are you putting something that's insensate? That's why people do well, versus are you really restoring anatomy for the patient? Yeah, thank you.
Yeah, great question. So to our knowledge, I don't think there's been any papers, and I searched it up, that uses the proximal tib-fib joint for reconstruction of these lateral plateau fractures. As to your second question, post-operatively, I know I think more longer-term follow-up is needed, but at least in the short term, none of the patients have reported of instability or pain along the proximal tib-fib joint. But admittedly, we're not really looking for that too. We're not like stressing it while the patients are in here because they're not having any problems there. But I think the most important thing for these patients is being able to restore their ability to walk again and relatively pain-free, which these patients have been doing. And I think for your last question, I think most of that comes from being able to restore that anatomy. I think from some of those pictures, the contours of the articular facets of the tib-fib joint actually fits quite nicely to the pieces that we try to mold to. And so I think and as mentioned, one of the patients that we had, they were now having like valgus or varus instability, indicating that the depression was fixed and it's a stable plateau.
A question for Dr. Dong. Is it possible to think about a vascularized transfer? And I ask that question because I know in the hand world, they'll sometimes transfer part of the trochlea with a vessel to the radius where you've got an osteochondral defect. But do you know if there's a vascular angiosome or something there that might allow you to use this as a vascularized transfer someplace else in the body?
That is certainly an interesting thought. To be honest, I haven't really thought about that, but I think that's potentially something worth investigating as we have more cases that are amenable to the use of this technique.
Interesting to see if there is much symptomatology of the tib-fib joint. I've actually taken care of a number of patients with tib-fib instability issues, many young gymnasts I've seen, and so it's a joint that I worry a little bit about, but maybe in a lower demand patient it doesn't matter, but it'd be interesting to see how they do long term, if that missing part of their joint matters or does not matter.
Yeah, absolutely. I think we want to be able to follow these patients for the long term. I mean, eventually they might stop showing up to clinic, but we can always reach back out to them and see how they're doing and if they have any development of any new pain or instability at that joint. But also importantly, while we're doing this technique, we're taking sure not to minimize disruption to like the capsular ligamentous attachments of the proximal tib-fib joint. I know, for example, fibular head resections have been used to address instability or pain at the proximal tib-fib joint. The main thing is preserving the LCL and the biceps attachments that we do here.
Yeah. I've seen some resections not do very well, a lot of symptomatology. I don't have a question for Dr. Martin, but I did want to call you out. I thought your figures and there's a great book called The Visual Display of Information by Edmund Tufte from 40, 50 years ago, but you exhibit a lot of his principles, but I thought your figures and the way you put the size and the characters and the differences were really visually appealing, so compliments on that.
Thank you.
I'll back that up with a question for you as well. So in addition, you looked at body mass index. Obviously, that's a relatively, ubiquitous clinical parameter that we see for patients, or we have recorded for patients. Were there other risk factors you looked at for, reoperation or non-union, whatever terminology you want to use, and if you haven't, which ones are you planning to look at?
Absolutely. So we pulled as much data as we thought would be relevant from prior literature. So we looked at ASA score, we coded for diabetes, steroid use, even whether it was open, the grade of openness, the mechanism of injury. We haven't done a multivariate analysis yet, but all of those things which have been previously shown to be factors contributing to non-union or associated with non-union have been pulled from our database. So we are going to look at all of those and see which ones may correlate or actually may be independent variables.
Any other questions? Oh.
Great job over there. Because you got praise, right? Great slides. We ask more questions for you. So, I want to, kind of ask. So dual plating is what you recommended.
Dual fixation.
Dual
So we actually
fixation, yeah.
used strut graft is considered dual fixation for us. Nail plate is also dual fixation. So any kind of second means of fixation other than just either a nail or a plate.
Okay, that's great over there because that's sometimes what we use in shoulders also. My questions for you is that obviously lots of patients, which is great. Have you looked at why they actually don't go into union or what the reoperation reason is? Because there is the difference in terms of like, is it a mechanical stability issue when you actually have failure versus is this a healing potential that, there's some discussion about people with high BMI, maybe is a metabolic challenge, state, actually may not have great healing potential. That may change your technique in surgery, right? Yeah.
Absolutely. Out of all of those factors, the only one that we've so far pulled from the database is infection. So we did pull those that were associated with infection. Again, we haven't done a subgroup analysis on those, but that's one of the factors we've pulled. We could certainly go back and look at any kind of metabolic factors that are associated. The benefit of we get to use this Kaiser database is that you have a lot of multidisciplinary notes associated with it, and then all the preoperative anesthesia notes I've also found have been very helpful in kind of trying to determine the other medical factors that are contributing to the non-union. So thank you. We should definitely continue to use our database as best we can.
It's a great job. Yeah.
Thank you.
All right. It seems appropriate to give our chair the last question. So we can go ahead and wrap up this section. We'll have a short break, and thank you guys for the speakers in this session. We appreciate it. We will take a quick break. Make sure to get your scoring sheets over to Deborah over here. And we will be back around 11:13 to hear from Dr. Shea, our keynote speaker. We're going to go ahead and get started. If you're grabbing food, feel free to grab food. Feel free to eat quietly in your seats. We'll just try to stay on track here. So next up is going to be Dr. Ma, who's going to introduce Dr. Kevin Shea.
Okay, hey, I thought I'm chatting over here.
You put the mic on you. Yeah?
So sorry, but I thought I'm kind of waiting for lunch. I'm chatting over here, so enjoying myself. So thank you. Well, great. Well, it's my honor and pleasure to kind of welcome our keynote speaker, Dr. Kevin Shea. Dr. Shea is actually a professor of orthopedic surgery at Stanford University. And he actually joined Stanford 2018. We actually share some passion about riding bikes. He showed me, how many miles, 9,000 miles last year, in terms of, biking, even more than what he's put on his truck over there. So Kevin's done a lot of great work. I think, I do sports medicine similar to him. And actually, he has done a lot of great work in terms of look at pediatric sports injury, leader of the ROC group, also PRISM. He's actually the current president of POSDA. I think just started this year 2025. And one tidbit over here, Lee, I think you'll be proud of this, is that the ROC group got the OREF grant 2011. I'm sure that Dr. Shea was kind of instrumental in that. So showing the residents about what OREF is about. I think a lot of us actually benefit from the foundation. I myself share with you that I got my first grant, launched my career. I got a few grants over the years, and also a lot of my faculty and actually trainees were able to kind of benefit from this program. So when you kind of move forward, or even now, support this foundation. I think as a group, as orthopedic surgeon, we need to have foundation like this to allow us to kind of really drive innovation and make difference in terms of how we take care of patients. So I'm going to turn the podium to Dr. Shea, my friend over here, to talk about pediatric osteochondritis dissecans. Thank you. Yeah.
All right. Yeah, it's great to be here. It's nice to come to a great meeting and not have to fly across the country. So really great presentations, and nice to see some old face, Deborah Cummings, who I think you and I did some work on the OCD guideline together years ago, and many other guidelines. And OREF actually took a guideline from the Academy and helped us form ROC. We got a $20,000 grant to have a foundational meeting to start a multi-center research group. And so thank you, OREF, for that support going back quite some time. So I'm going to talk about one of my hobbies, if you will, about dissections and anatomy. First of all, no conflicts. Everything's up to date on the Academy and AOSSM website. But just a little bit of wisdom from Jack Houston, who said that orthopedics is basically anatomy and common sense. And so pay attention to your anatomy lessons. And I've never gotten tired of going to the lab and dissecting things. And I've been doing this, I can't believe it, it's almost 25 years. As of this last year, we're over 400 knees, pediatric knees we've dissected over the last 13 years. And we've got almost 80 publications on different types of things, both knee anatomy, development, biomechanics, a lot of stuff on vascularity of the meniscus and the condyles, physo relationships. We've pretty much looked at almost every major ligament. We're starting to look at some of the smaller ligaments. We've got a lot of stuff on the pediatric adolescent knee. Really interested in ACL graft options, and appreciated the ACL talk related stuff and the meniscus stuff earlier today. We'll talk a little bit maybe about quad tendon, because that's getting a lot of attention. Maybe it has some discussion at the end if we have time to talk about LAT procedures and the anatomy and how the pediatric knee probably needs more LATs than maybe the adult knee, because it's the highest risk group for re-tears. Talk about some challenges about how we might think about repairing the meniscus. And I'm not going to talk about it today, but we've done a lot of work on the development of the patellofemoral joint and how that impacts both the development of trochlea, and maybe gives us some insight as to why we have so many patella instability issues, especially in female athletes. So just going back in time a little bit, when I started thinking about this, and early on in our training, we were told you don't fix the ACL in kids because you're going to end up with a growth plate injury. And so a lot of kids were treated with braces or activity restrictions, which doesn't work very well because kids don't restrict their activities and they won't wear their braces. They're like dogs, you operate on them, you put a cone of Shane on them because they won't do what you tell them to do. Kids are the same. Well, over the last 15, 20 years, we've really spent a lot of time thinking about how can we reconstruct the ACL, how can we get these kids back to sports, how can we help with their not just physical but emotional and social development, because sports are a big part of that. But you got to be careful with this because there's multiple publications on showing deformities that you can cause in kids with a traditional adult ACL reconstruction with graft choices and drill hole position can cause all kinds of deformity. There is some interesting literature from almost 30, 40 years ago that you can damage the growth plate to a certain amount, maybe 3% of the volume. To go above 7% of the volume, you're more likely to have an arrest. That literature isn't great, but there is some data that some injury is tolerated okay. But for those of you who've done any guided growth, I know we had a guided growth talk on the seminar that dropped off, but you can easily produce a degree a month sometimes in these kids in a peak growth period. You can cause 10 degree of angular change within 6 to 10 months. So you got to be careful with any type of physeal injury. And when I first started looking at this after coming out of my training, I was really trying to understand, how can we put the optimal growth plates in the pediatric knee, but hopefully preserve or spare the physis. I spent about 6 years trying to get pediatric tissue. I wrote people, I called people, Europe, even India, United States. I couldn't find any, and after 6 or 7 years, I about gave up, and I got a phone call from Allosource, who said, hey, we've got a little knee for you. And so 2008, they got us like, 8, 9-month-old knee, and myself and Ted Ganley flew into Colorado for a day, and we spent the day dissecting this little teeny knee, and it was amazing to learn a little more about the anatomy from that one knee. If you think about a lot of things that develop in the knee, the ACL is very distinct in utero by 10 weeks, and by 20 weeks, ACL, PCL, they're small, but they're clearly the same structurally as they are in the adult knee. This is one of my favorite photos. When I was doing one of the dissections, they had a bandsaw in the adjacent lab, so I took the femur over and I just went right down the center of the femur because I wanted to understand that ACL-FISA relationship. But so that's right fresh off the bandsaw there. And that would be, if you will, an all-pistol drill hole. You can see how you could avoid the physis, but a typical drill hole, typical one we'd place for an adult would go right across the physis. And this is also the peripheral location of the physis, which is bad because it's much more likely to cause a growth plate problem. So we published a couple papers early on trying to understand the anatomy a little bit better and really to understand how far away are you when you're drilling all epiphyseal or transphyseal. How close are you to cartilage? How close are you to the physis? And how anatomic can you be? And so we looked at this in our small knees, under a year or two, the distance was about 6 millimeters. But in the older knees, it was only about 8 or 9 millimeters. So even in an 8, 9-year-old, you're still not that far away from the physis when you're placing a drill hole. So you gotta keep that in mind. And here's just one of the pictures from one of the publications kind of summarizing that distance to the physis and the ACL. So bear in mind in that, 8, 11-year-old, which is the kids we're treating, you're not that far away. So you gotta be careful. If you're off by 4 or 5 millimeters, you might score right along that physis and cause a longitudinal rest. So Alan Anderson, who developed this all-epiphyseal procedure, I don't know if any of you have met or knew Alan, wonderful guy, and he was involved with our research for quite a while. Ted Ganley has done a lot of modifications of this, kind of evolving on different drilling approaches. The concept of the intra-articular injury or intra-articular location is the same, but the location of the tunnels and the type of tunnels has evolved. Alan initially did all full-length tunnels, but we found that definitely have a greater risk of physeal injury. No surprise, a longer tunnel close to the physis has a higher probability of injuring the physis. And so there was an evolution with Ted Ganley to using short sockets, 10, 15, 20 millimeter sockets, and a short socket versus a full-length tunnel obviously is probably safer. I don't know if there's many people who have done the Elizaroff world, but the concept SAR, structures at risk, is a big part of the Elizaroff deformity world when you're doing lengthening and other things, but you got to think about other things that are at risk, and I think same thing applies to the knee. You can use the x-ray in many ways to guide your placement, especially for injuring the physis, because you can see that, but you can't necessarily see everything else. And so we'll talk a little bit about some extra-articular structures that, as we've done some of this anatomy work, we were able to look at this on pediatric knees. Things that I think are at risk, ALL, LET, we all pay a lot of attention to that now, the popliteus, lateral collateral ligament, and the physis, and of course the cartilage on the back of the knee. If you have a full-length drill hole, you got to be really cognizant that you could potentially take out one or more of these structures with a full-length drill hole, and if you miss coming out the back, you can hit the cartilage. And I've not personally seen that, but I've seen that happen in patients who the drill hole came out into the joint laterally. So you got to be careful about all these things. After kind of dissecting these knees and doing some three-dimensional modeling, Alan initially wanted to stick with his full-length tunnels, but after going through this work with Alan for a couple of years and with Ted Ganley, we basically changed the way Alan started doing this all-epiphyseal drilling, where we moved from long full-length tunnels that exited the lateral side of the femur to short sockets. This had the advantages: you're not going to injure the ALL, the popliteus, LCL, anything on that lateral side. And in some ways, it's a little faster surgery to not have to do a full-length tunnel. So there's some other studies that have been done looking at physeal injuries, and on the femur, it's probably pretty safe because you've got a bigger volume of tissue and an origin which is probably far enough away that you're not too likely to damage that. And Frank Cardasco and Hollis Potter and Dan Green and some others looked at some of their pediatric patients who had post-op all-epiphyseal ACL MRIs completed, and they showed that when they got the MRI, only 1 of 14 had evidence of direct injury to the physis with their drill hole. And I think of this, I'm from Idaho, so there's a lot of target shooting up there. This is a bigger target and an easier shot. So you got that red on the periphery is the physis, bigger target, you got more space to shoot, and you're less likely to damage it. So now let's go to the tibia. Unfortunately, it's the exact opposite. 13 of 14 of their tibias had evidence of experienced surgeons damaging the physis while not intending to do so. And I think this is a much harder shot. You got a smaller target with the same size bullet, unfortunately, but you're a lot closer there. So keep that in mind. We're going to talk about this a little bit more about that tibial risk, because it's just a much narrower zone to shoot for. So just to summarize, the ACL, it's in the notch, and it's not that far away from the physis, so be careful when you're drilling there. All epiphyseal drill holes are close to the physis. A lower starting point on the femur is going to be safer than a higher starting point. And once again, a shorter socket is going to have less risk of an injury because you just don't have as much real estate that you're damaging with a small socket. Now let's talk a little bit more about the tibia. Once again, your radiographic landmarks in the OR can help you. That AP view might look like you're going through the physis, but if you understand the three-dimensional nature of the physis, you're not. But that AP and lateral view can really help you by placing a guide pin first. But we've got some nice models here. We'll kind of try and talk about this because there's some risks that I don't think it's easy to understand until you start looking at three-dimensional models. But if you're too low, you're going to hit the physis or the apophysis and cause potentially recurvatum growth disturbance. If you're too high, you're going to get that meniscus root. A very shallow angle creates a more elliptical aperture, which expands and can get the meniscus root. And if you get even more shallow, you're going to potentially have a blowout. You won't have any fixation strength because you've gotten too shallow and your hole is now massive. And so you got to be careful on that. A couple of things, and Alan Anderson pointed this out to me, that as you get more medial with your drill hole, the physis position is more narrow. He would encourage me to be as close to the patella tendon as possible. So he'd even say, retract the patella tendon when you're putting in that tibial drill hole because you have a higher vertical volume of physis, which is more distal. And so that really stands out clear when we're in the lab working with Alan. But keep that in mind. If you're drilling on the tibia, stay as lateral as possible, as close to that patella tendon, because Alan really felt that was critical for not getting a growth plate arrest. So here's actually a pediatric cadaver and just some arrows. Just highlight, there's the physis, and there's your joint line. And you can see there's a pretty limited window for drilling. That drill hole there avoids the physis, and that drill hole crosses the physis. And these drill holes are not that far apart, so keep that in mind. The lower drill hole works fine for an adult, but for a kid with lots of growth remaining, probably don't want to put that drill hole there. One other thing to keep in mind is the ACL is very close to the roots, especially the lateral root. And as that drill hole aperture goes from a vertical tunnel that's just round to a horizontal tunnel, which is ovoid, you get a bigger zone of injury. And so here's just an example of a knee. So steeper angle, round, shallow angle, elliptical, and then very ovoid. You can see how that ovoid will extend in and damage the anterior root, primarily the lateral meniscus and possibly the medial meniscus as well if you're not careful. So just a couple summary lessons here. You got a narrow window on the epiphysis on the tibia, and it's definitely challenging on smaller knees, and that's why on really young knees I typically won't do all epiphyseal drilling on the tibia because I think it's hard to get that target right, just because it's so much easier to injure it. So keep in mind, stay as close to the patella tendon as you can, and try not to get too low, because you get too low, you injure the physis, but if you get too high, you'll enter the joint and hit the meniscus root if you're not careful. And once again, I typically use a Micheli-Coker modified Macintosh procedure in the younger kids just for that concern about damaging that physis. So I think all epiphyseal ACL reconstruction is technically a pretty challenging procedure, especially if you're going to try to not injure the physis. And I think any time you're going to do one of these, it's really important to talk to the families about it, because we still see case reports of growth disturbance after this procedure. So just let the families know we're going to have to follow you, and there's a possibility we might have to address a growth disturbance on either the femur or the tibia, or possibly both in the femur. And once again, the tunnel drilling, you just got to be really careful with your pin placement and think very carefully as you're drilling, because you got a pretty small space and you're not that far away from the physis. And don't forget, there's other structures at risk, especially on the lateral side of the femur. I think many of you are familiar with sort of the, Macintosh described this long ago, and Micheli kind of popularized it. But this was a procedure that was basically an over-the-top femur and tibia. It's been looked at biomechanically, and the biomechanical performance is pretty good. There's probably a little over-constraint on rotation that maybe not be ideal, but in essence, it's over-the-top ACL femur, over-the-top ACL tibia with an LET. Anatomic concerns is it really anatomic, because over-the-top is not really the femoral origin on the femur, and over-the-top on the tibia is arguably too proximal and too anterior. The other challenge is that getting the iliotibial band graft size correct can be challenging as well, because a lot of times they end up too small, and so there's some challenges with that. So when I first started doing these procedures, having dissected some knees, you take a probe or something to pass this graft behind the knee or pass a suture and then pull it through, but knowing my anatomy, I said, wow, that seems awfully close to two nerves and an artery. And so I was always kind of nervous doing this procedure, and so I got nervous, and so I printed up some 3D models to try and look at instruments and say, can I design a better instrument, or is there an ideal arc of curvature on a tonsil or something? So we played around with that, but then the next thing we did is we had enough cadaver knees one year, we actually simulated this, and so this is just a simulation. And so this is the back of the knee. We're looking at the popliteal fossa. That hemostat, if you will, is how you would pass an iliotibial band graft. And so the red arrow is at the tip of the instrument. And so red, that's the popliteal artery, and blue is the nerve. So you can see that you're not that far away. And so here's a nice dissection view where we actually measured the distance from the tip of your coker or your hemostat or wherever you're passing to the peroneal nerve, the tibial nerve, and the vessel. And you can see, depending a little bit on the age group, we sort of base this by age groups, but in many cases you're less than a centimeter or right around a centimeter, the tip of your instrument, from one of those structures. So that's not that far away. So keep that in mind when you're passing that instrument. Keep that on the periosteum of the femur. Don't come off the back of the femur, because you might wrap yourself around a nerve or an artery and wake up with a foot drop or a vascular problem. So once again, this is very close to those neurovascular structures. You should all be a little paranoid, and you want to make sure that an experienced person is passing this instrument. This is probably not something you want the least experienced surgeon in the room to do, unless you've sort of maybe passed it first to create a channel, and then let them feel the instrument gliding along the periosteum, but it's not that far away, so be careful if you're doing this type of graft passage. So we had a nice talk about quad tendons earlier today. I probably did my first quad tendon 14 or 15 years ago. I wasn't using it as my primary choice, but I was using it for a multi-lig case and occasional revision. But I've probably been doing for 14, 15 years, a lot more for the last 4 years. But it's gotten a lot of attention. And one of the first things that I was concerned about when I was doing rectus tendons is we don't do many rectus tendon transfers anymore, but at one stage, if you had a child with spastic gait problem and they had an overactive quad, so their leg quad was too active, their leg was fully extended, and they would catch their toe and trip, you would take the rectus tendon, transfer to the hamstrings, because the rectus usually fired out of sync more so than the rest of the quad. The rectus now became a hamstring to improve knee flexion. And I did that early on in my career. It's not used as much, but we did it early on in our career for neuromuscular and during my fellowship in San Diego. And I know we have some San Diego folks here. You know that's was all the verification work and gait lab work was done by Sutherland and Chambers and others down there. But I knew the anatomy, and I was always worried that if I harvest a quad tendon, is the quad tendon going to, or the rectus muscle belly going to retract, because you're essentially releasing the rectus tendon potentially with a harvest. And I was worried that this would cause quad weakness, and we know probably at least a quarter of the quad strength is directly from the rectus, and it also crosses the hip joint, so it's a double joint thing. I took care of a lot of skiers when I was in Idaho, and I was a ski patroller, and I saw a number of mogul skiers who had ruptured their rectus, probably 8 or 9 of them over 15 years there. I don't know why they kept rupturing them, but they were profoundly weak with a rectus rupture, and I did a lot of delayed rectus rupture repairs because you get this ball of muscle, but they were so weak they wanted it repaired. And so it made me worry about using a quad tendon graft for an ACL. And so we actually looked at a number of pediatric knees, published this paper a few years ago, but typically that rectus separation is very distinct, somewhere between 3 and 5 centimeters above the superior pole of the patella. It's a little bit size variation, but about the width of the patella, your rectus is going to separate about the width of that patient's patella. And I think if you don't consider that separation, how easy it would be for that rectus muscle belly to retract, you could end up with some quad weakness. And there is some gait lab data looking at quad tendons, that the quad tendons are struggling with a little more quad weakness, whereas hamstring tendons struggle with hamstring weakness at 9, 10 months afterwards. And so I think really, and I do that when I close my quad, because it's now my most common graft, is I make sure that when I'm passing my sutures through there, I'm attaching the vastus medialis to the rectus, to the vas lateralis, because I want to make sure there's no possibility of a rectus retraction in the future. I've not seen it, and I'm probably close to 600 quad tendons now, ACLs, and I've not seen it in my own patients yet, but I have seen 2 cases of rectus retraction after quad tendon harvest outside my own practice. So once again, just anatomically, here's that interval where the rectus proximally separates, and I think really trying to close that interval carefully so it is not possible for it to retract or recess like we do when we're trying to lengthen tendons. So once again, I think we should be cautious about this, and I encourage all of you to look at this. I think we might be missing this because quad weakness in some ways might be a modest rectus retraction problem, not that there's a problem with the quad. So keep that in mind as you're taking these graphs, and also look for it if you're seeing patients with profound weakness or maybe more weakness than you expect in their quad group after on. Wrap up once again, ACLs, growth plate complications, you got to think about that a lot. Meniscus injury, you got to think about that too if you're drilling, depending on root repairs. We don't have much in the way yet on that in terms of, I don't know of any case reports yet of root repair growth plate disturbance, but something you got to think about going forward. Those neurovascular structures, if you're doing that iliotibial band passage, just keep that tip of that instrument on there and be a little paranoid when you're passing that. It's always good to be paranoid as a surgeon, right? Be real paranoid when you're passing behind the femur. And quad tendon harvest, we just talked about, make sure you close that interval. So I'm going to finish well ahead of time, so I'll have time for questions, but I'm going to challenge everyone to think a little bit differently, because I think one of the things that dissecting all these knees has really made me start to question a lot of things that I have been taught about both the anatomy, but also about the techniques for repairing the meniscus or stabilizing the meniscus. We treat discoid meniscus, which is a funny thing because we can have tears and peripheral instability and absent coronary ligaments or absent MTLC. So that has stimulated my thinking, but dissecting all these knees and looking at these structures has also changed the way I think about meniscus repair. So I'm going to challenge all of you to follow me along this path here. First, I want to talk about the SCORE registry. Some of you may know about this. This was a gift from the ABOS. Jim Castor approached me in 2012 and he said, the ABOS wants to start a prospective quality registry. You got any ideas? And I said, I do. How about a pediatric sports registry? And he said, okay, we'll give you 5 years of funding to launch the registry. So he came to us in 2012, and it took us about 4 or 5 years to do the business associate agreements, data use agreements, and to build a software platform. We used the ABOS software registry, and we launched this in 2018. And it wasn't designed to be necessarily an outcomes registry in the traditional sense or research registry. It started out as a performance quality improvement tool. And the reason we started it that way is that IRBs look really hard at sharing data with anyone else, and it puts a lot of obstacles. But there is a National Health and Human Services exemption for performance and quality improvement registries, because the Health and Human Services says that if we put obstacles to collect data to improve quality, we're going to hurt patients. And the IRB is designed to protect patients. And so there's actually an exemption where you can use data differently for research, or rather for performance quality improvement purposes, as opposed to research hypothesis-driven projects. And so we started it truly as a quality improvement registry, in part because we knew that would help us get more centers to get IRB approval quickly. This registry has become very powerful, and it's now really starting to spit out data, as all these registries are an investment. They take time. Like ROC took 7 or 8 years before we published our first good series of papers, and SCORE is now doing the same thing. But what's been really helpful is we have insider information on what type of meniscus tears we're seeing, what type of failures we're seeing, what type of suture patterns are being used to repair things, and which ones are failing at higher rates or succeeding at higher rates. So a lot of the SCORE data helps me drive sort of the anatomy data as well. So this is just a picture. This is a dissected knee. It's a disarticulated femur has been taken off. So we're looking axial view down on the tibia. Okay. And so I've just added a few little highlights here. And I'm not sure, is the arrow moving on the screen for you all? Okay, no arrow for you guys. But the red arrows, is it moving? Okay, there's a mouse. All right. The red arrow is kind of the back of the meniscus there. Those dots are this deep recess or this fold. The green is obviously the popliteus tendon. The blue arrows are sort of the back of the capsule. There's this very redundant patchless capsule that extends below the joint line. It's not seen as much on the medial and lateral aspects, but it's definitely anterior and it's clear posterior. And I think I've got a little video. I'm just going to play this video for you here.
Okay, so this is a 2-year-old.
Is this connected to audio?
Highlight some of the differences between the meniscotibial ligaments and the capsular structure. So here we are.
Can you guys turn the volume up? Is that something I do?
A layer of capsule off the back of the femur, just to show.
Might have to go all the way up and see what happens. Okay. If it's too loud, we'll turn it down. There's an area, just click in there and there's a little arrow. Yep.
Laser pointer. So now you as you scroll here, it'll be up there.
Great. Let's see if I hit the arrow. Does it play? Get any audio? Here, go back. Click right there. There's an embedded video here. I'll show you. There's an embedded video. Hopefully I'll click that and it'll play.
Turn the highlighter off. There you
Go
go.
to laser pointer.
Okay, so this is a 2-year-old knee, and I want to highlight some of the differences between the meniscotibial ligaments and the capsular structures. So here we are medial meniscus, and we've dissected a layer of capsule off the back of the femur, just to show, here's our capsular layer right here, and there's this recess here, and you can look down this recess, you can pull free bodies out of here when you're doing PCL reconstructions. This recess allows you to see your PCL drilling. Here is the meniscus, right here, the posterior rim, heading towards the medial collateral ligament area, but this recess is very clearly defined, and here is this capsule right here. When we do meniscus repairs, both with inside out, outside in, and with all inside devices, we are, in many cases, if not all of them, we are putting our sutures through the meniscus here and tethering it to the capsule. We're essentially closing these layers together, if you will. We're pulling them together, and we're going to demonstrate that later with a suture. I'm going to make the argument that there may be cases in which we want to sew the meniscus to the meniscus tibial, or rather the meniscal tibial ligament here, or the coronary ligaments, and not to the capsule, because if we sew it to the capsule, we potentially peripheralize the meniscus, and we approximate or close down this meniscal capsular space by putting sutures right there. Same thing as we shift over to the lateral side. Here, suture, there's attached to the popliteus tendon. You can see the popliteus tendon right here. Here's the bare area of the meniscus with no coronary ligaments or meniscal tibial ligaments. Here is the capsular fold recess. Here is the... Okay, I'm just going to show you some diagrams of what I'm trying to illustrate in that video and audio there. But just looking at that cross section, this is a pediatric knee, but it could be an adult knee. Just remove the physis. But you see that red line is the meniscotibial ligament complex, if you will, and that capsule folds down and then comes back up. You know, where the MTLC stops and the capsule begins, I don't know exactly. That's almost a religious question, but there's clearly a blending of those tissues. But when you close that with a suture, which is what we do with inside out, outside in, and most all-inside devices, is we're pulling the capsule to the meniscus. And that's not anatomic in much of the knee. And as I've looked at more and more knees, and even arthroscopically, I challenge all of you to look with the scope and see, because I think it'll make a little bit more sense. So increasingly, I'm looking at ways to do this. I've done this in a few cases, and we're doing some lab work on trying to figure this out. But I think there are parts of the knee where you might want to not sew the meniscus to the capsule if you're trying to stabilize the meniscus for a couple reasons, and we'll talk a little bit more about that. But I hope these diagrams just kind of summarize. There's with no suture. There's suturing to the capsule, closing down that space. And here's not closing down the space. We all know when we have transplants, what's one of the biggest reasons transplants probably fail is the extrusion rate. The meniscus doesn't necessarily fail, but 3, 5, 7 years later, the MRI show the menisci have extruded. Almost all meniscus transplants are repaired by multiple fixations of the capsule rather than multiple fixations to the tibia. And I know some people are starting to think differently about that, but I've been struggling with this for about 8, 9 years now, and I think that may be one of the challenges we have with discoid meniscus instability and with meniscus transplants. So I'm just challenging y'all, think differently, because I don't have the answers yet. I'm thinking about this a lot. We're playing around in the lab. I see Ben's getting sick to his stomach over there saying I'm crazy. I look forward to him challenging me. But I think incorporating that meniscotibial ligament tissue and that sort of the concept of not sewing to the capsule in all areas, maybe in some areas, but not all areas, may be helpful. And I can tell you in particular, I have a fair number of discoid meniscus where there's anterior rim instability, and the space between the joint capsule and the anterior rim of the meniscus is huge. And if I sew that anterior meniscus to the capsule, I pull the meniscus off the tibia. So I sew it to the meniscotibial ligament complex, sometimes just with sutures, sometimes with suture anchors in the tibia, and sutures through the meniscus. But I think we all need to think a little bit differently about meniscus stabilization repair, both for unstable menisci, which we see in the discoid world and sometimes in the traumatic world, but in maybe the transplant world as well. I also think the ramp lesions, I think repairing ramp lesions to the posterior capsule is very non-anatomic, and I think we should be repairing ramp lesions to the ramp. They come off the tibia, right? That's where we should be repairing them. So just to give you a quick little summary, these are some things this just got published, I think, last month. This is our first, this has actually got completed about 2.5 years ago. It took us a while to get it published. But this was defining the anatomy and the biomechanics of the medial and lateral meniscotibial ligament complex in the posterior 1/3, the middle 1/3, and anterior 1/3, because I wanted to understand how strong is this tissue. I'm going to start repairing it with sutures, anchors, whatever. How strong do I have to be? So this gives us how strong it is in each one of these regions. And so we've got nice data on that. Just to summarize this paper, we found there clearly is a space in between the meniscus, the meniscotibial ligament complex, and the capsule. The central and posterior regions of this tissue are quite strong. The anterior tissue is not quite as strong, which makes sense, right? The posterior meniscus has more load. We'd expect the posterior meniscotibial ligament complex to be stronger. And once again, I'm raising that same issue that I think there's certain meniscus tear patterns or meniscus stabilization things we're going to do, or ramp lesions or discoids, which we might think about incorporating this in repair. And so this was to, okay, what is the biomechanics? What is the anatomy of this tissue? So our next one is, and this hasn't been published yet, but we just submitted this for abstracts, is we're looking at the biomechanics of repair. So we're now repairing pediatric menisci in the lab and looking at anchor placement, anchor performance under load, and suture performance under load while we're repairing these. And so this is the abstract, but this is a picture of something we just submitted. But we found that last year in 24, we placed implants in an open tibia model, which is easy to do, right? Anyone can do that. It's like shooting fish in a barrel. Guess what? The performance of anchors in kids, depending on how you place them and load them, is very good, like close to 200 Newton pull-out strength, which is great. I didn't know if we could duplicate that arthroscopically, and so this last summer in June, I had 7 surgeons with 15 different knees, 7 surgery teams implanted anchors arthroscopically to confirm we could do it arthroscopically, and we've shown almost identical performance. So both open and arthroscopic placement, these anchors perform well, and they exceed the native strength of the meniscotibial ligament complex. So this is just some of the background work that we're doing right now. So I think we're going to be spending a lot more time, at least I am, trying to figure out normal meniscus mobility. The nice thing about having access to pediatric tissue is that I'm able to start doing biomechanical studies on pediatric bone and pediatric menisci, which is interesting. Pediatric bone generally performs worse than adults for suture anchor pullout. Pediatric menisci has been performing better for meniscus repairs. The pediatric tissue is more durable. Sutures don't cut through, they don't fail as quick. So it's good to have pediatric menisci. It may not be as good to have pediatric bone. But we're really trying to understand this. We've got a lot of things coming out on meniscus repair, especially radial tear repair, because it's got a high failure rate. It's part of that crab. We had the crab discussion earlier. That's basically, and sometimes you have a root radial tear and you have a mid-body radial tear, so it's like a double radial tear. It's a double crab. That's a really bad thing. We're doing a lot of work on root tear attachments, and we're finding that, like in the adult world, the pediatric knee, if you fix the meniscus root at the joint level, it outperforms tying sutures over a bone bridge significantly. It does so in adults, we know that. It also does so in kids. The joint level fixation in kids is remarkably good. I didn't think it would be that good. And we're also learning that tibial fixation, at least anterior for suture anchors, and meniscus stabilization is working very well. So a lot of work continues to be done. This has been a 15-year journey, maybe even a little bit longer, and it's been a lot of fun. But the families who make the decisions to donate their children to allow us to do this work, I mean, it's really remarkable. And every year we send a letter, and every year we summarize all the research we've done in the last year, all the publications we have. We share it with Allosource, and they share it with the families who have made these remarkable decisions to offer these donations to help us get better. These all come from Allosource out of Denver, Colorado. And also the ROC, the PRISM, the Rocket teams have been a huge part of this work, none of which would happen without them. And probably the best part is we have a number of college medical students, residents and fellows who come every year to our sort of dissection cadaver biomechanics course. And so I want to thank them, because without them coming and always asking great, insightful questions and pointing out deficiencies in my logic, we'd never get any better. So that's it. Thank you. Take some questions or harassments or criticisms, condescension.
I'm going to start first. First is thank you. This is really great over there. I learned a lot, from your talk, and a lot of them are music to my ears, by the way. Kevin, I think the residents laughing in the back over there. Maybe I'll get, I'm going to pull Natalie over there. Maybe Natalie share with us a little bit about, what you did with the meniscus, repair a week ago about, some of the, discussion that Dr. Shea did, in terms of the tear near the posterior root. I think what you're pointing out is exactly, what, we're thinking too, is that fixing the posterior medial meniscus to the capsule is actually you basically, displacing meniscus posteriorly. We kind of fall behind, fall onto it because of the inside out technique, and now with all the tools. Yeah. But Natalie did some case with us, last week. Maybe share with us what we did. Yeah.
Can you get a microphone? Thank you.
Yeah, so we fixed a posterior horn of medial meniscus tear. We made a sort of accessory portal posteriorly, and then used PDS to come in from the outside and then fix to the capsule posteriorly.
Yeah.
Which is basically like fixing to rim, kind of what you just said, instead of fixing the cap. So I think this is, something we need to evolve, as a community. And also my questions for you, I think the resident laughing in the back too, is that how long do we need to have sockets to be when we're doing ACL? Like we talk about 15, 20, full tunnels. How long should we do?
Yeah, and the presentation this morning from, Grant about how much bone plug do we need? Because if you have a 10 millimeter bone plug, why have a 20 millimeter tunnel? So I think the bone plug and the tunnel need to match. And I don't know if we know the minimum size. For me personally, I rarely go longer than 17, 18 on a tunnel, even in a bigger kid. But I try never to be less than 14 or 15, depending on the length of the graft and a few other factors. But for me, it's somewhere between maybe 15 and 18 is kind of the range I use. But that's just what I do. I don't have great data behind that. I know there was something, Bob Burks talked about some years ago, that anything less than about 10 or 15 millimeters, or maybe it was 15 millimeters, the interference screw fixation on a BTP plug wasn't adequate. So he felt 15 was the minimum length you should have on a BTP. But that, of course, if you have an 8 millimeter graft versus a 10 millimeter graft, that may affect that. I don't do much BTB anymore. I had about 700 BTBs early on in my career, and I don't use them much anymore, partly because of the anterior knee pain issue. So it's not as relevant to me, but I do mainly soft tissues, occasionally hamstrings, but mainly quads now. And so I think for me, it's about 15 is the shortest, but I don't have an answer. Maybe someone else does. Ben, do you have a number? Do you have a minimum number, a maximum number?
What's my minimum right now, guys?
5mm femoral socket.
Yeah, so we, I think that's why I think that for all the learners too is that challenge the norm, because a lot of times why research is fun, because a lot of things we do in orthopedics and also in life is being passed on by maybe other people. Doesn't mean that it's going to be applicable what you do now, and also it could be different. You learn more about it. So the 1520 is really about using bone plugs for your patella tendons. That's why the interference screw need to be 20mm long, because fixation. But soft tissue graft, there's no number. We just translate that number because we use BTB in the 90s, and then we kind of use that number. So now we're actually using really short sockets right now. And short socket, you can imagine if you do all epiphyseal ACL, have only a socket of maybe 5 to 10mm. You don't have to worry about injury in the physes because you're far away from that over there. So little things that we actually modify may change our practice, but we actually have some data coming out right now. But no, this is no controversy at all. I think these are all setting standards right now, Kevin. So thanks for kind of doing this, sharing it with us. That's awesome. Yeah.
I recently, I did a PCL avulsion in a 12-year-old, and normally it was just an isolated PCL, and normally I wouldn't necessarily fix those. In adults, I treated a lot of isolated PCLs without surgery and was pretty happy with those. But this kid, he had a grade 4 laxity. It was way back, and it was a nice avulsion off the tib, and I thought, well, let me just see if I can pull that back in. And so I did a little 5mm socket, and I put some running sutures in it. I put 4 running sutures in it. I pulled it through the socket and pulled it through an all epiphyseal 5mm deep by I think 8mm diameter hole, and was able to pull it into the hole just by putting a little socket in there. But all I did was 5mm because I couldn't have pulled it anymore, right? Because only so it was intact, but it was pulled off. I couldn't have pulled in 10. There wasn't enough PCL to do that, and I intentionally put the socket a little proximal because if I put it real distal, I wouldn't have been able to pull any of it in. So I intentionally, because the PCL actually crosses the physis. The PCL origin is epiphyseal, physeal, and metaphyseal, and so I think you can safely do an all epiphyseal socket and be reasonably anatomic.
It's great. Any questions? Brian, yeah.
Yeah, I'm a traumatologist, but I like to think that I do a lot of meniscal repairs, mostly on the lateral side, on plateaus. But yeah, in training, I was pulling the meniscus out, tying it down to doing repairs and pulling it out, tying it down to the plate, tying it through the IT band. Then I basically stopped doing that completely, and there's certainly no ill effect. I just wanted to let that meniscus move and move normally. But my question was for you, and I think I probably just missed it, but the recess that you're talking about, is that medial and lateral, or that's more posterior on the meniscus, or?
It's very distinct posterior medial and posterior lateral, and very distinct anterior medial and anterior lateral. On the collateral side, especially in the MCL, the meniscus is really blended in with the MCL, so you can't really find that recess as well. But on the posterior and anterior, it's a very distinct recess, yeah. And as a traumatologist, thank you for saving the meniscus. I appreciate your efforts here, because I'm always trying to save the meniscus, and I appreciate the traumatologists are the same, especially for your knee work. So thank you. I think you might be able to use some suture anchors, where you could actually put sutures in a meniscus if you felt you need some stability, and just I know suture anchors are kind of sportsy, and you don't like doing that sportsy stuff in the trauma world, but it's super fast. You pass the suture, put an anchor in, it takes 10 seconds. It's probably faster than trying to tie it over the plate.
Hey, Kevin. Obviously, you have the next generation in front of us right now. Maybe share with us, I think for me to just, we can hear the passion, see the passion what you have, in terms of, doing, research, innovation. Maybe share with them, what advice you have for them. They're starting their career right now. What drives you? What kind of makes you keep on asking the question, trying to innovate, and, why are you in this business for so long doing this over here, and how do you inspire them on that? Yeah.
Yeah, so there's a lot of academic talent here. I am a country doc from Idaho. I practiced in 19 years and then came to Stanford 7 years ago. I grew up in Montana.
In Palo Alto right now.
Yeah, but I am the simple-minded country doc. Lauren was a resident, one of the first residents I worked with, and she can assure you how simple-minded I am. So I may not be the best person to ask, but I just really, almost all the research I do is directly related to things that I take clinically. Take care of a lot of meniscus tears, so I do research on that. ACL tears, I do a lot of research on that. I was in private practice for most of my career, and we had to run a business. I basically feel like I have an MBA based on managing practice with 6, 7
6 separate business lines: research company, DME, physical therapy company, ambulatory surgery center. We had to run all those, and so I learned a lot about running businesses and managing finances in a group. And so whenever I was in, I just took advantage of everything that was around me, and if I felt I could do something better or I could learn something more about it, I would just dig in on that. I think probably the best decision I made is I tried to build a research program at Boise State University Engineering School. Tried for about 6-7 years, spent a lot of my own money and time, tried to get some grant money, and we built a gate lab and some other things, but it was really hard to convert a non-academic institution into an academic thing. And so I decided my decision to found ROC, which grew out of a clinical practice guideline with Dr. Cummings here, helped us start with the academy. I felt that the thing that would make me most successful would be form multi-center partnerships. And so ROC was the first one. PRISM, Pediatric Research and Sports Medicine Group, which was 6 people talking around a fireplace at a ROC meeting, and then 10 years later there was 500 members. And SCORE, the outcome registry, and we got a couple other things that we're planning on right now, but get involved in multi-center study groups. You don't have to lead them, but you can join them, and if you're willing to put the time into it, you can get a lot done. I was in private practice most of my life and was able to just keep asking questions and find the right people to work with. And that meant I had to collaborate outside of Boise, Idaho, because we don't have a med school or residents or grad students or anything like that. So I'd encourage you to get involved in multi-center research groups, because I think the key to the future, I mean, why is machine learning so powerful? Because you get larger and larger data sets to answer questions with greater accuracy and a lower probability of being wrong with your answers. And to me, multi-center study groups are doing the same thing. We're getting more data, and the answers and conclusions are less likely to be wrong because we refine it with better data sets. So get involved with multi-center study groups. You might even be able to found some. I was in private practice, started 3 in private practice, and so just get involved. And you don't have to be in a big academic center. Now that I'm at Stanford, I should have come here years ago, because now I'm in a supercharged environment where I can actually get a lot more done. It's really hard in private practice, but it's not impossible. I published 140 articles in private practice without any support at all. So you can do it, but it's going to require a lot more work. If you find a good academic institution, or even if you're in a private institution, if you partner with an academic institution, I think you can become, really powerful. What I mean by power is answering questions so you can provide better care for your patients. To me, that's what power is. It's not about what people think about power, money, prestige, wealth, influence. No. How do we take better care of our patients? And if you just every day get up, think, how can I take better care of my patients? How can I do better surgery? How can I manage this practice better? I do a lot of supply chain work. I'm medical director for supply chain for the Children's Hospital and down in Stanford. I've been doing supply chain work my whole career because I want to provide better values for patients. Deborah Cummings, who's focused on value and quality and clinical practice guidelines, that's part of my brainwashing is, just get passionate about what you do. And you don't have to be in a big famous center to do really amazing work, for sure. I don't like boasting, but I actually think the ROC group is the single best orthopedic acronym out there, right? What's better than the ROC group, right? Research for osteochondritis dissecans. How much better does it get? So PRISM, SCORE, Mars, Moon, Pluto, Anchor. Yeah, how many are there, Ben? There's, yeah, and they usually have to be celestial orbs of some type, but anyway. Yeah, thanks.
All right. Well, we're at the tail end here. So first of all, thank you to all of you for being here. Thanks to all the residents who presented, the students and faculty who were here as well. So thank you for making this successful. Thank you to Dr. Shea for hopefully a short drive up, from South Bay, and for Dr. Ma for, allowing us to host at our institution, and of course to the OREF for granting us this honor. We have awards. And so let's get started with those. Do you want to go first?
Also, before awards, there's going to be a group photo. After the awards, we're all going to exit there, take a quick photo, and then we will let you go. All right. Well, we're going to start with the presenter's choice. This was a tie. So the winners for this one are Oliver Dong and Nicole Newman-Hung. So you guys can come on up. unprecedented tie. All right, and we're gonna go
We're gonna go
third
third.
place. Thanks, guys.
Thank you, guys. Congrats. All right, third place.
One, two, three. Yeah.
Third place. All right, for third place, we have 3 people for third place. It goes in by order. So Kelechi Nwachuku, Alexa Pius, and Karch Smith. Kelechi may not be here.
All right. Second place, there are 2 second place winners, Grant Schroeder and Mathangi Sridharan.
So just a reminder for all the award winners, just talk to Carmen, just so she has your address and can send you your check, which is obviously very important. And then also another reminder, everybody just stay back for just a few minutes. We'll just get a group picture as well. And then first place prize goes to Kyla Petrie.
Just a reminder, the first place and the 2 second place advance to national. So we'll be getting information about
Good luck.
November 12th.
Okay, that's a wrap. Thank you, everybody. KJ.